Good morning, everyone. We're going to go ahead and get started. First of all, before I roll in, I just want to remind all the speakers as well as all the commissioners that to make sure that we make proper use of the microphones for recording purposes, and also for those who may be viewing online. This ensures that they're able to hear the comments and the questions and the information that's going to be provided today. So thank you very much for everybody being here today. I know it's raining and a lot of difficulty getting in, so thank you for all of your ability to get here today. Appreciate all of you and what's us moving forward. With that, I'm going to go ahead and enter into the roll call. First, Mr. Allen.
Here.
Ms. Butcher.
Here.
Dr. Freeman.
Here.
Secretary Friedlander.
Here.
Representative Fugit.
Here.
Mr. Ingram.
Here.
Ms. Kelly.
Here.
Treasurer Metcalf.
Here.
Ms. Purdy.
Here.
Dr. Roop.
Here.
And with that, we have all parties with us and we have a quorum, and we will move forward with this. That being said, I'd like to move into the adoption of our agenda. At this time, may I have a motion to approve the agenda?
So moved. Seconded.
Motion made and seconded. All in favor?
Aye.
The motion passes. Next, I want to make sure just to put on the record the business schedule for the upcoming meetings for the commission. The next meeting will be September 10th, 2024 at 1 p.m. And the meeting after that, and the last one for this year, will be November 12th, 2024 at 1 p.m. All business meetings will take place at the Capitol Annex, 702 Capitol Ave, Frankfort, Kentucky, 40601. With that, we will move forward into the next section, which covers the minutes. And I want to, hopefully all of you have had the opportunity to review the minutes from the last meeting. And at this time, I'm going to ask if I may have a motion to approve the minutes.
I move we approve the minutes. I second it.
Motion made by Ms. Butcher, Ms. Purdy seconds. All in favor?
Aye.
Any opposed? The motion passes. Thank you very much for that. Next, just a few updates that I'd like to provide to the commission and those with us today. First of all, I want to make sure I have the opportunity to welcome Representative Fugit and Ms. Kelly to the commission. We thank both of you for being with us. We know both of you have a rich history with the knowledge and work in this area, and we appreciate your service. We recognize you have a lot of other things going on at this time, so we're thankful for your service. At this time, I also want to give both of you an opportunity if there's any comments you'd like to make. At this time, I want to make sure you have the opportunity to do so. With that, let's go.
Thank you. Thank you, Colin. I am honored to be here, certainly honored to be Senator Stivers.
Thank you very much. Representative Fugit?
Thank you, sir. I do appreciate the opportunity to serve on this commission. I worked 22 years with the state police, with the last 9.5 to 10 years on the Hydro Drug Task Force, which focused on drug trafficking and opioids and Oxycontin and all that coming into East Kentucky at that time. And so I've saw firsthand the devastation to our families and children, and also I appreciate the opportunity to serve, and hopefully can be a good voice for what needs to be done. I appreciate it.
Thank you very much. We appreciate that. And again, thank you to both of you for joining us. Next update that I just want to provide is, as the commission members were updated previously, the staff is working on research and information request related to innovation and research in the Commonwealth. What is being pushed forward first will be a request for information, and I want just to update the commission members that process is taking place and continuing, and we hope and anticipate that request for information will be able to be pushed out next month, so that people understand that process continues forward, ultimately looking to see if we can push out a research request for funding request for folks to make sure that we as a commission and that the Commonwealth looks forward in terms of being innovative in other options and researches in treating the scourge. So we want to make sure that you all know that that process is still ongoing and still moving forward. And then the last thing I have for the updates is last week, commission members and staff began conducting official site visits to the 2023 sites that were granted awards. So everybody is aware that that process is underway. And as all commission members have been made of those dates and what looks forward, we welcome you to that, but we want to make sure that you and the public know that that has begun and that is underway. That is the last for the updates that I have. Moving forward and trying to make sure we get into today's practice and the meat of what we're here for. We want to move forward into the priority setting presentations. And so again, as we've discussed and want to make sure to clear is that what we're looking for today is to get some insights in the morning half about what options are out there, what the landscape looks like, and to help learn some information on the current trends that are taking place, not just in Kentucky, but also across the country. We have the opportunity to have some outstanding experts in the field who are known nationally in terms of the scope and understanding of the crisis and what we're facing. So we're thankful for having them here with us today. And as we go through, we'll make sure that we're able to do that. The second half of the day, we'll take an opportunity to hear from all of you about what your priorities are, what you think the priorities of this commission ought to be as we move forward. That will be an opportunity for you to voice based on your experiences, based on what you've seen from prior grant applications, what we should focus on and what that looks like. So we'll be spending the afternoon having that discussion. But with that, we'll go ahead and to move forward into discussions from the subject matter experts. So at this time, I'd like to ask if Sarah Whaley and Dave Lucas are able to join us. If you could come to the front, we'd appreciate that, and we'll go ahead. So just as they're getting set up, to provide some background for the commission members as well as those present, Sarah Whaley is a senior practice associate at the Johns Hopkins Bloomberg School of Public Health and the director of programs of the Bloomberg Overdose Prevention Initiative at the Johns Hopkins Schools. She has experience in both opioid treatment and harm reduction research and direct service intervention. Sarah's goal as an advocate is to use research to inform policies that improve the health and well-being of individuals who use drugs and their families. Secondly, Dave Lucas is a drug policy advisor and social work educator committed to promoting equity at the intersection of substance use, healthcare, housing, and the criminal legal system. In his current role as a senior advisor at Vital Strategies, he oversees a broad array of overdose prevention and policy reforms initiatives in the Commonwealth of Kentucky. Prior to this, Dave served as a clinical advisor at the Center for Justice Innovation, providing training and technical assistance to judges, lawyers, law enforcement, and clinical teams on evidence-based overdose prevention and treatment practices. With that, I'd like to welcome the two of you to the Commission Day, and I thank you for coming in to join us, and I'd open it to you for any comments and then for your presentation.
We have to click. Thank you so much for having us here today. Just want to say thank you to all of you for the work that you do and just all of the great work that's happening here in Kentucky. I think Dave's going to start us off with a few words.
Yeah, we flipped a coin and I think I'll tee it up. So hello and good morning, everyone. Thank you, Mr. Evans and Ms. Halliday, and our esteemed commission members for the invitation to join you all today. As mentioned, my name is Dave Lucas, and I'm a senior advisor at Vital Strategies. And we are a global public health organization based in New York City. I am part of an overdose prevention core team, our only US-based initiative, and we are backed by Bloomberg Philanthropies. The overdose prevention team works across 7 states, including Michigan, Pennsylvania, New Mexico, New Jersey, and North Carolina. And I, of course, have the privilege of overseeing all of our projects and partnerships in the Commonwealth of Kentucky. I'm really excited to finally be here in the Capitol. I spend over 40 hours a week in Kentucky virtually on Zoom, maybe even more than 40 spiritually. Kentucky's in my dreams. But it's always nice to be here physically and finally meet our partners in person. I'm thrilled to be here presenting with my colleagues from Johns Hopkins. We have Sarah Whaley presenting and Samantha Harris in the body. I know Sarah has a lot to cover today, so I'll keep my comments about our work brief. For those who are not familiar, we kicked off our work in Kentucky in 2021 and will continue through to the fall of 2026. Our initiative involves grant making, research, technical assistance covering a wide range of overdose prevention strategies that include expanding access to medications for opioid use disorder, low-dose naloxone, low-barrier housing and healthcare, and non-police crisis response models. We listen to the data, to Kentucky's community members and other local experts, and as such, racial and geographic equity is a critical through line for all of our projects. Most days, this portfolio feels really busy and expansive. We are currently funding around 15 organizations and/or projects, and with about 20 more in the pipeline. This includes support for grassroots service providers, grass top policy analysts, partnerships with state and local health departments, universities, planned work with hospitals, treatment providers, jails, prisons, law enforcement. We back research. Sometimes we do it ourselves. We build toolkits, fund art projects, radio campaigns, and we're building up in-state TA capacity. We currently have 2 embedded staff within state agencies, KDPH and KYOAAC. We have Lauren Carr from KYOAAC here today. And we have 1 more staff starting next month and another in the fall. Like the partners we fund, we aim to be data-driven, equitable, and sustainable. And like our partners and the commission, I'm sure, we know that the stakes are high and the steep price of getting this wrong. I am incredibly proud of the work I get to be a small part of in Kentucky, but I also know that there are gaps too big for our budget and our timeline. And so that's why I'm really excited and honored to be here today, to meet and learn from other folks making similar difficult decisions every day about how to invest in our communities and working to improve and save the lives of Kentuckians. With that, I'll pass it to Sarah.
Thanks, Dave. It's always great to hear about how much work is happening here. And like Dave mentioned, as part of the Bloomberg Overdose Prevention Initiative, they also fund Johns Hopkins to do, there's 2 teams that are funded. We have a research and evaluation arm that our work in Kentucky is led by Samantha Harris. We also have what we call a government support team. And that's the team that I get to work on. And I have led our portfolio on opioid settlements and opioid settlement best practices. So I've been asked to come here today and share with you some examples from across the nation for your consideration of how different states have approached opioid settlements and have used the opioid settlement principles. So just to put into context, across the nation, we're looking at somewhere around $50 to $56 billion that is going to state and local governments from these lawsuits against the companies for their role in contributing to the opioid epidemic. There have been so many different approaches taken by states in how they are allocating funds. There's some defaults in the settlements of how much money is going to state and how much is going to local governments. But a lot of states have changed that, and they've done it in a variety of different ways. So this map just shows the variety of different approaches to settlement funds and the mechanisms that different states have used. So some have used MOUs or MOAs. Some, like Kentucky, have used law or legislation to set up their system. Other states have used a combination. So just a lot of variety in approaches to opioid settlement funds. Just a bit of kind of where the money is going. 12% of funds are going directly to cities. 38% are going directly to counties. And then the other 50% is going to states or trusts or some combination of that. So really an interesting look at just across the country where the money is going and who has control of the decision-making of where the dollars go. You may be familiar with the principles. This is a set of 5 high-level guiding principles that the team at Johns Hopkins released about 4 years ago. We have a website. You can see our URL in the corner. These principles have been endorsed by over 60 national organizations, and we meet monthly in a working group with about 20 to 30 of these organizations to troubleshoot things that we're seeing across the country, to figure out who's best equipped to provide technical assistance, and to really coordinate resources so that folks like yourselves who are really in this important position to make decisions of how these dollars are used get a coordinated message and don't get contradictory guidance and information. So I'm going to go through each one of the principles really briefly. I've heard that you guys know about them, so I won't belabor that point. But for each principle, I'm going to share at least one example of a state or jurisdiction that has used that principle in an interesting way that you may want to consider as you think about the next year of opioid settlement funds in Kentucky. So principle one is to spend money to save lives. This one, I think, is the basis of all of the principles, but really investing the dollars in the opioid epidemic. We believe that the kind of core of this principle is to invest in programs and to supplement the existing work that is being done in a jurisdiction instead of replacing other funding sources with opioid settlement funds when possible. So how do we know what needs to be invested in or what existing funding sources there are? And this is often done through some form of needs assessment. My numbers on slides never transfer over. So sorry, that's 1 and 1. It should be 1 and 2. The first example comes out of Nevada. So Nevada used a decent chunk of their first distribution of funds to contract with an outside entity to conduct a really in-depth needs assessment. They didn't have a current one. They hadn't done any kind of needs assessment in a while, so they thought that this was an important investment for the future of their opioid settlement funds. So they contracted with this outside entity to conduct a really thorough needs assessment. We have also seen a lot of jurisdictions do a less intensive, more community-based needs assessment approach. So partnering with the health department to look at existing quantitative data, partnering with community-based organizations to do key stakeholder interviews, to look at what is currently available in terms of resources, how the different programs across the state are doing. Are they effective? So is the money that's already being invested in these programs actually showing the intended output? Looking at existing funding sources and how those are being leveraged. So we know that opioid settlement funds have a bit more of a nimble approach. They're not as restrictive as some federal funding sources. So looking at what's being funded and how we can bring opioid settlement funds into supporting existingly funded programs in a way that uses the dollars most effectively. And then looking at service gaps and key challenges. So these key stakeholder interviews can be really important to learn what's not working, and again, use opioid settlement funds to fill in those gaps. So that's needs assessment. And that brings us to our second principle, which is using evidence to guide the spending. Obviously, in needs assessment, there's a lot of evidence, but this principle, we really focus on 2 key tenets: investing in proven programs and promising programs. And I think sometimes the balance of how do we invest in evidence-based programs, but we also want to be innovative and think about new emerging programs that don't have as strong of evidence base. So how do we balance investing in both of those types of programming? So the first one I'm going to share comes out of Virginia, and this is Virginia has really used their opioid settlement funds to incentivize evidence-based programs. So in Virginia, they also have a council or commission similar to you all called the Virginia Opioid Abatement Authority. This authority oversees 55% of the funds in Virginia. Another 30% goes straight to the local governments, where local governments have full control over the decision making there. So what the authority wanted to do in Virginia is use the state portion of the funds to incentivize the local governments to do the right thing or invest in evidence-based programs. So they offered an additional 25% of their funds to go to cities and counties that commit to only using their funds for abatement purposes. And they have an outline of what meets that criteria. In order to receive extra funds, cities and counties have to report required performance measures. So there's a set list of measures that have to be submitted back to the authority for review in a statewide analysis of effectiveness. And then in addition, the authority also provides TA support through what they call an abatement academy, which provides best practice examples to cities and counties for each one of the 5 principles. They also provide best practice examples of evidence-based programming, and they provide twice monthly live webinars to the cities and counties around different evidence-based program options. So this is really an opportunity to use the state money to have an impact in local communities. So I think this is a really interesting example. The next example is funding innovative strategies. So in Colorado, the state has 15%, and of their 10% of the state share is in what they call an innovations fund. So this innovations fund is a series of grants that community-based organizations can apply for that may not meet the criteria of evidence-based. But in their grant proposals, they have to show how this innovative strategy is anchored in evidence. So it's not evidence-based, but it's informed by evidence. They need to demonstrate why this is a needed innovation. They need to show community collaboration. So how are they working with other evidence-based programs? And then they need to show some kind of evaluation protocol. So how are they showing that this innovative strategy is, again, having the intended outcome? And then they also need to show a sustainability plan. So these are short-term grants, micro grants, but a way to kind of balance in the state of Colorado, investing in the tried and true, the proven, but also keeping some opportunity open to explore new opportunities as well. All right, principle 3 is investing in youth prevention. There are a lot of different types of primary youth prevention. We know some are rooted in evidence and others are not as strongly rooted in evidence. But a core tenet of this principle is really building youth resilience. These are the types of programs that have seen kind of the strongest evidence base. So some examples across the country include addressing the social determinants of health. So in Cambria County, Pennsylvania, they did a local needs assessment, and they found an interesting a piece of information that they weren't expecting. Their schools had, I think it was like a 9-month waiting list for students to see a mental health care provider within the school. So they determined that this was an area of need and one that they could do something about. So they partnered with a local university that had a school-based mental health master's program where those students have to do an internship. And so they were able to place master's students in local middle and high schools to provide mental health support. I have a master's of social work. I did an internship like this in a school in Baltimore City, so had supervision from a licensed clinician, but was able to provide extra support in the school. So I think these types of programs are really great, just my personal opinion. The second example here is in Boston, Massachusetts. They, in the city, in addition to the city's chunk of money, they set aside a portion of funds for what they call an economic support for impacted families fund. So this family overdose support fund provides resources to families who have lost a loved one to an overdose. And these financial resources can be for funeral expenses, mental health supports for family members, legal services, childcare, or other just financial burdens for individuals who have lost a family member to an overdose. All right, principle 4 is focusing on racial equity. a core tenet of this principle is just investing in disproportionately impacted communities. So a couple ways to go about doing this is investing in systems changes. So Washington County, Minnesota really made a strong commitment to empower marginalized communities in the decision-making of their opioid settlement funds. So they really wanted to make all of their county systems more accessible to marginalized communities. They made a commitment to value lived experience and lived expertise. So their council and commission included community representatives and people with lived and living experience. They did a needs assessment that included individuals from the carceral system. So that was something unique we've seen in the needs assessment, was actually going and doing key stakeholder interviews with individuals who were involved in the criminal justice system. And they are really focusing their efforts shifting from what the county was originally doing into more of a public health approach. So using measures of success that are based on larger population health outcomes versus individual outcomes. So like, did a person, stay abstinent? Did they stay on their medication? But they really wanted to look at like more broad health outcomes as kind of the measure of success for their opioid settlement funds. Another example in Principle 4 is investing in infrastructure. So in Cuyahoga County, Ohio, they are a little bit of a unique kind of case study here because they were one of the counties to get a large lump sum payment from the opioid settlement fund. So they had kind of this opportunity to invest in infrastructure. So they used their funds to invest in the creation of a diversion center to get people out of, or to divert them away from the criminal justice system and into a more health-based system. So first responders, police, EMS, instead of arresting an individual, can take them to this diversion center where there is a bed for them at all hours of the night. They can be connected to treatment if that's what they want. They can be connected to other types of services if that is kind of what they need. So they are able to take that person into a safe space. We know that a lot of times, depending on the hour or availability of beds, sometimes jail is the only option, unfortunately. And so this diversion center really helps, was really an option in Cuyahoga County to get away from that as a model. Again, an option, just in thinking about infrastructure, Colorado, in addition to their innovations fund, has a separate chunk of money that they have set aside for infrastructure investments. So something to think about as you're thinking about like your 50%, the different types of funds that you can create. And infrastructure funds may be one of those. And last but not least is to develop a fair and transparent process. So I have three kind of words here at the bottom of the slide: to listen, to evaluate, and to disclose. So listen, we've talked already about needs assessment and really listening to key stakeholders, being inclusive of diverse voices in kind of identifying what the real needs are. Evaluation, I think an important piece here is looking at, are the programs that you are investing opioid settlement funds into, are they having the intended outcome? So are they doing what they said they were going to do? And we have at Johns Hopkins partnered with Vital Strategies to create a set of standardized indicators that can be used by a jurisdiction. You can include it in RFPs so that there's like a set metric for output. We call this tool Osprey. It's on our website, and I've said Colorado a lot today, but Colorado is using Osprey. They have a regional fund, and the regions have to use OSPRI, some OSPRI measures to report back to the state. So this is a tool that can be used to kind of standardize the outputs. So in Colorado, they'll be able to compare across region the different types of programs. Everybody's going to be reporting on similar measures. So there's an opportunity for comparison there. And then the last one is disclosure. So it's something that I talk a lot about and often get interviewed by the press about, this disclosure piece. We know that you guys are under a lot of pressure in the decisions that you're making. This role is not an easy one. And there is a lot of pressure, and there is kind of this magnifying glass on you for the decisions that you're making. Disclosure to the public is really important, as you know, and that transparency in your decision making. So just a few pieces that I point out is disclosing how much money is going to organizations, where it's going, why is it going there. So really knowing why you're making these decisions and sharing that information with the public. And then again, looking at, did your investment have the intended output? And I think sometimes we make investments and they don't pan out the way we thought, and that's okay. You know, sometimes things don't work out, and there's a variety of reasons why they don't. We can't control kind of all of these factors. So I think just being transparent about the things that are working and also the things that aren't, and how you're pivoting when things don't work the way that they intended. So those are some pieces of Principle 5. Again, our website with the resources I mentioned are there. We also have a series of other resources from us and other groups, and always happy to answer any questions. Thank you so much for your time.
Thank you very much. We appreciate that. Before we lose you, I want to make sure that there's, don't get up yet. There's an opportunity, if there's any questions from any of the commission members that they have for even the panelists, I'd open the opportunity up at this time.
I have a
Hi,
Hello.
thank you for your presentation. I'm representing a district that's highly diverse in Jefferson County, one of the largest counties we have here. So I'm very interested in your research on how Jefferson County has been included in any of your research or studies. And also have a second question about the cities that were, the example you gave of Virginia. Did they also have a separate budget aside from these funds that were given? Or was it this was the only pot they received?
So in Virginia, let me just also make sure I'm saying the right number. So 30% of kind of the state's total, the total that the state received, 30% of that went directly to the local governments. 55% went to the commission to oversee, and then another 15% went directly to the state.
Okay.
So the authority used 25% of their 55% math to incentivize the local government. So local governments could spend their 30% however they wanted, right? The state or the authority had no oversight in how they're spending their money. And that was concerning to the authority because I think early on we saw some investments that maybe weren't in line with evidence-based. And so to incentivize evidence-based practices, the authority said, okay, local governments, we will give you an additional 25% of our money if you meet these standards. So I thought that was a really interesting and nimble way of thinking about their money and using the money that the authority oversaw to incentivize best practices like in local communities.
Okay. And the other question about how do you include diversity? What are you doing to outreach to those areas that are not as astute to applying for these sorts of grants? What kind of things can be done to incentivize where the need seriously is in some of these pockets that are being forgotten or just not being a part of the studies or the narrative or outcomes data?
Yeah. If there was one question I got today, I'm glad it's that one. We actually have a couple different projects that are looking at that specifically. So the first one is our racial equity RFP that was a $500,000 micro grant, very low barrier. The application process was very simple, and the idea was to reach out to Black-led or Black-serving organizations across Kentucky, but we did get a lot of applicants, not surprisingly, in Fayette and Jefferson.
Sure.
And so there'll be 11 sort of micro grants for organizations to build up their overdose prevention, stigma efforts, naloxone awareness. So they don't necessarily have to be serving drug users entirely. They just need to be working in that community and building up that aspect of their work. And they'll be given some TA along with that if this is the first time that they've ever done it. So some training, some materials. So we're not excited that something like that is needed, but we're excited that we can actually, help stand up some of that work in areas that really needs it. We also are partnered with a few organizations in Louisville that do that work directly, work with those populations directly. Kentucky Harm Reduction Coalition, I'm sure you know them. Seeds a New Leaf. And we're working on a contract right now with Deacon McKenzie at the Kentucky Behavioral Health Center to really do some significant capacity building as they are situated in West Louisville, which we know is a significant hotspot. We also are in the process in partnership to some extent with the state to do some radio campaigns targeting Black audiences to raise awareness about where you can get naloxone in those communities as well. As far as our own research in those areas, we really rely on our state partners and organizations like KYOAAC and ODCP for the data, and our experts in Kentucky to help us understand where the need is. But we try to think about this about equities beyond sort of the major urban centers as well, so geographic, any parts of the state that have major racialized or geographic disparities in overdose because of transportation or lack of culturally appropriate or responsive services available. So it's like I mentioned, it's a through line in all of our work, but the need is there when we announce a 10% decrease in overdose. But that we know that doesn't apply to all Kentuckians. We know that there's a lot of work still to be done there. So. And
final question I have: when we talk about diversity, it's not just racial. Yeah. Are you looking at other types of diversity where you're being more inclusive of all groups?
Yeah, I think we, to some extent, we are just working with the demographic data that we have, and because that jumps out to us as a very glaring need, that's sort of where we started. Mm-hmm. We are two of the organizations in that equity RFP are serving LGBTQ+ organizations as well. Pregnant and parenting, so we're concerned with maternal health and overdose as well. I think the main thing that we learned in our first year is listening to the community was economic and transportation really exacerbates all of the other equity issues in the state. And so we try to think about partnering with organizations that at least plug some of those gaps as we think about ways to more systemically bring services to people where they are.
Okay. Thank you.
And I'll just add, when thinking about kind of the grants that you all are giving out, we've seen this in other states that they're using the RFP process and adapting it slightly to community-based organizations that are minority-led. So that could be like adapting reporting requirements. I would again point to the Osprey tool. You can say to those groups, like, just making like the burden of reporting kind of less, since sometimes these groups have less capacity than like maybe the larger or more established community-based groups. So thinking about how you guys can adapt your either reporting requirements or RFP requirements to get more minority-led community-based organizations to apply for grants or micro grants. Did I have another point? I think that's it. Yeah.
Thank you.
Listen,
Mr. Chairman.
yes.
Thank you, Mr. Chairman. I had a question for you, Ms. Whaley and Dr. Whaley. Thank you for being here today. I'm from a small community, and we have a lot of demographics that would certainly favor an Appalachian model, a demographic. When I was county attorney, I started an anti-drug coalition, and we were drawing from law enforcement, from the schools, from medical and religious to get a cross cut of the community. In talking to the people who were working in the schools and in law enforcement and so on, one of the things that came up fairly often was the need for drug testing on a large scale. Let's say, by large scale, I don't mean the entire county. I mean it within a school system, and it would be inclusive of teachers, administrators, as well as students. These schools, in particular, had already adopted a model whereby students who are receiving the ability to travel, such as academic excellence groups, as well as athletes, and those who drove to school were already being subject to drug testing. What would be your thought, please, on the value of drug testing inside school systems to obviously reveal the extent of any problems that might exist with substance abuse among high schoolers?
Thank you for that question. So I think these large-scale drug testing initiatives, while I think they can be informative, I also want to point out how stigmatizing that can be and kind of the negative impacts that something like that might have. Rather than drug testing, I might point you towards like screening for individuals. So using something like an expert tool to screen for opioid use disorder or opioid use. SBIRT allows for screening and then a brief intervention. So if someone does screen in that they might be at risk of or have an opioid use disorder, then providing access to some other kind of support. So whether that's treatment or something else. So rather than drug testing, I might point you towards screening as an intervention. Again, the stigma piece I think is big. There are individuals who have opioid use disorder that are on treatment that may show, depending on the medication that they're on, might show a positive on a drug screening, on a drug test. I will just in full transparency say that I have not done a lot of work or read a lot of studies on kind of these large scale drug testing initiatives. I don't know if Samantha or Dave have thoughts on that.
Well, maybe one thing I'll pull on some of my background working in the drug court world for a good chunk of my career. One thing that we observed during COVID when we weren't able to, I say we, but when folks in that field weren't able to drug test in the normal course, what they found was that a lot of people continued to disclose their use anyways, and a lot of that they attributed to the fact that they had a strong and trusting alliance with their service providers, whether those were treatment providers or case managers or probation workers, and they sort of relished the opportunity to have those honest conversations and to just disclose in a way that wasn't sort of, mandated or looking to catch somebody. I think also a drug test has a very, very narrow capacity to assess the scope and the severity of a problem. The presence of a substance in somebody's bloodstream is only tells a very small part of the story, and to really know the story, how much somebody's struggling, what their needs are, what's going on at home, requires investment in schools and school counselors. We heard about the wait list for mental health professionals. So by the time we're drug testing kids and catching them using, or teachers, it's probably too late. That would be my assessment. I don't know of any good long-term studies that show that scaling drug testing has any sort of preventative. I think it's evidence-based in certain sort of court-supervised treatment structures, but in terms of a prevention strategy, I've never seen anything supporting it. I know people are interested in it, but I haven't seen any evidence backing it.
Mike, there we go. you know, I hear both of you saying that it's probably does more harm than good. Would that be a good summary? I see people nodding in agreement with that statement. My concern here, obviously, is not to out people. It's not to stigmatize. One of the problems that teachers and school officials raised with me was we'd like to know more about our kids. The ones that are falling asleep in class, they may not be using drugs. They may just not be getting enough sleep at night. The other problems that goes to your point, sir, that there's much more to this than just a screen. And the whole purpose that we adopted inside our programs was to educate as opposed to do something that would be result in ostracization or stigmatization of these students. I believe that the one that seemed to work the best and have the most profound good results was in a family court setting, which is what you were addressing, or in a prosecution setting, having people continue to drug screen who had already been charged with crimes or had been determined not to be able to manage their households. In other words, children were placed at risk. In Kentucky, we call that DNA court. DNA court would be where children are being neglected or abused. And we have family members who are responsible for them. In those situations, we found that continuing to test for opioids or even marijuana was very helpful in those situations. Do you have any comments on that?
Before you get too far, I'd just ask if you can move forward a little bit quickly, just because we might need to make sure we get to the other speakers.
I was just looking at the agenda. I'll be very quick. My sense of in any kind of problem-solving court model, there's proximal and distal goals, and what the evidence seems to show is that drug testing works really well in the early days with participants who sort of are new to recovery, new to not using. It provides a pretty powerful incentive to stop using. It's an external incentive, obviously, at first. But the evidence shows that you want to be steadily decreasing drug testing as somebody moves through these programs, because you want that motivation and that change and that recovery to be more internalized. When it continues to be really stringent and really frequent as it continues, the evidence for supporting it goes down. So it does tell you that there is a positive effect for a particular population, but it's temporal, and eventually you want to be reducing and then stopping drug testing altogether. So it has again like a limited and narrow, but the evidence does in those models specifically does seem to support its efficacy, at least in reducing use. Affecting other changes in somebody's life, that's maybe a separate question.
Those are good. I think those answers are based on experience and some testing or perhaps studies that you all have done or are familiar with. So they're very helpful. Thank you.
And I'll just point out that, the effectiveness in the court system is probably not the same as in a school. And I don't think we want to make schools similar to court systems.
Well, let me point out, just so that you understand, I'm not
Yeah.
interested in adopting a model like that. I think you both made the differentiation between a court setting and a non-court setting. So those are very helpful answers.
And the SBIRT tool can be used by school social workers and school nurses. So I think that might be maybe a more effective tool in school systems.
All right. Thank you very much. I'm going to have us move on to the next phase. Thank you very much. Again, my understanding is you will be here later on today also. So if there are other questions later on during discussions period, they will be available at that time also. Thank you very much today. We greatly appreciate that. As we move into our next speaker, I want to make sure that we're going through, that'll be related to trends and data related to overdose deaths in Kentucky. While our two panelists are coming up, I want to make sure to handle a note of administrative matters that I've neglected to get to. Just as a reminder for those of you in attendance, if you'd like to speak during the public comments, please make sure to sign up at the sheet at the podium. Due to our busy schedule, we'll have a limited time for speaking, but we'll get to as many people as available. So I want to remind all the speakers that is available, an option if you choose to do so. please make yourself aware of that and available to that. Coming up next, we have is Dr. Dana Quisenberry, Associate Director of Kentucky Injury Prevention and Research Center, and Dr. Peter Rock, Director of Biomedical Data Science, the University of Kentucky, Rapid Action Data for Opioid Response in Kentucky. I'll leave it to that for that in the essence of time, but thank you very much for being with us today. And with that, I'd turn it over to you for opening comments and for your presentation. Microphone also is if we can continue on in the anticipated time, we've got Dr. Marks had some travel issues, so we'll see if she's going to be with us. So go ahead and move forward.
Okay.
We'll make sure to keep things on track.
All right. Thank you so much for the invitation to come and speak today.
Okay.
I greatly appreciate it. So a little bit of our agenda. We're going to talk about mortality and morbidity trends and the positive things that we are starting to see, as well as some of the things that are still concerning. And then we'll talk about other measures of progress that are happening in our state. As I was introduced, my name is Dana Quisenberry. I'm an assistant professor at the College of Public Health, University of Kentucky. I'm also our principal investigator for Overdose Data to Action, which is a CDC-funded program to conduct surveillance and prevention activities in order to prevent overdose. I am also focused in that work on the surveillance data. And we will start with fatal drug overdose. We have two particular measures that we look at. We look at fatal overdose and non-fatal overdose. And those two things provide us different actionable data. Fatal overdose, our opportunity to intervene for that individual is lost. However, what the information we can gain from understanding more about their death provides us some information to intervene for others. So we're going to start with the drug overdose trends. Just to be able to level set where we are, CDC nicely provides a metric in which we can compare ourselves to states and that other states, and that's an age-adjusted rate of overdose mortality. And as you can see, we are still dark blue. We rate at sixth among the 50 states in DC. West Virginia continues to be at the top, and their age-adjusted rate is nearly half again as large as ours. So we're making progress when we compare to other states, but remember this is a ranking, and so we may be doing better, others may be doing worse, and so rankings by themselves don't tell us exactly where we need to be. This graph represents to you the overdose counts over time. It's really small, and I apologize for that. And we're showing, this graph shows us that we have a decline in the number of Kentuckians who've overdosed and died in the last couple of years from our peak year of 2021. And it also gives you a small glimpse of what we are being able to report in 2024. Now I'm going to caution you because it looks really positive that that's less than half of where we were last year, but there are reporting limitations. And so this is better representative of a quarter of the year than it is the full half year. But still, progress. One of the big concerning pieces of our work, that our surveillance findings, is that the age-adjusted rate for Black Kentuckians has continued to increase. It was 6.7 in 2021, and in 2023 it's 6.83 Black Kentuckians per 100,000 residents. What's even more concerning is that the gap is widening between Black Kentuckians and white Kentuckians. We are seeing decreases among white Kentuckians. And due to our demographic distribution, we have to put all other races together in the other category. And we've seen a lot of fluctuation there. This is a very complicated slide. It is in the slide deck that you've received, but I do want to share a few distilled points with you. Up until 2015, other substances were the leading substances involved in the deaths of Black Kentuckians. In 2016, fentanyl overtook that and became the top substance involved in drug overdose deaths among Black Kentuckians. It was a little slower to take over amongst white Kentuckians, where prescription opioids were historically the most involved substance. And in 2017, fentanyl really began to influence the deaths of white Kentuckians as well. All of this needs to be looked at through the context of the fact that unilaterally, our drug deaths in Kentucky are polysubstance. So knowing what the top substance is not the full picture, but it gives us an indication of why we are seeing the increase in drug overdose deaths that we saw early on in this time frame of 2015 to 2023. The other thing that's really concerning is the disparities among age groups of Kentuckians. Van and I have been doing this work a long time, and the 35 to 44-year-old age group has been historically the most impacted age group. And that remains true even though we've seen the decreases in numbers. What's alarming is the increases that we've seen in the 0 to 4 years of age and our elderly population. While we saw decreases in every other age group, those two age groups continue to increase. Now, granted, the numbers are small, but it is a trend that we need to think about how we address moving forward. The other way to slice and dice surveillance data is to look at it by county. And we have two different metrics here. If we simply used the highest number of deaths, of course, our population centers would always be at the top, somewhat as a function of the density of the population. So when you look at the right here, these are the counties with the highest fentanyl-involved deaths among Kentucky residents. And just to give you some idea, it remains about 70% of our deaths involve fentanyl. So those are our population centers, right? Jefferson, Fayette, Kenton, Madison, Pike County in the east. And the counts do get smaller as we go down those, as the population also does. But when we look at the age-adjusted overdose rates, we see a different picture. We see the smaller counties with smaller counts, but they do have a large impact in those communities. And Estill County leads the top and has for a couple of years now with an age-adjusted rate of 187 deaths per 100,000 residents. Now, like I said, we no longer have an opportunity to intervene there. But here, when we start looking at non-fatal drug overdoses, the ability to intervene is different. So first, we want to look at the age-adjusted rates for emergency department visits for non-fatal drug overdoses. This is from 2019 to 2023. And as we can see, they are declining amongst, for all drugs and opioids. Stimulants remain pretty consistent, although there is a small decline. Age-adjusted rates for emergency visits by race, we see yet a continuation of what we saw with more the fatality data. Black Kentuckians are continuing to increase, even though there were slight declines between 20 and 21. They are not significantly measurable declines, where we're seeing declines among non-Hispanic whites, Kentuckians, and we're seeing increases among Hispanic residents. One of the things I do want to caveat when we start talking about drug involvement, before I switch to age groups, is that this is dependent on ICD-10 coding, which is a function of billing and reimbursement. So the capture of polysubstance is a lot more restricted in non-fatal overdoses, because they're wanting to intervene based on the toxidrome or the patient presentation, and that's what ends up getting coded for reimbursement. So the reliability of the substance involved in non-fatal overdoses is restricted. So age groups, we look a little different. We're a little younger. The 25 to 34 are our highest up until 2023, where it's pretty much neck and neck with the 35 to 44-year-old age groups. So our ability to intervene for younger age groups may have greater impact, since we know there may be multiple non-fatal overdoses prior to a fatal overdose. The question about Appalachia came up earlier. The red outlined counties are Kentucky Appalachian counties. And this is the distribution of the age-adjusted rates for emergency department visits for non-fatal drug overdoses by county. And I'm going to highlight for you that our darker counties, or those purple counties, are almost exclusively in Appalachian counties. And so the disparity amongst the distribution of these non-fatal overdoses is geographically disparate. And as you saw earlier, I didn't provide a similar slide for fatal overdose distribution, but I want to do that for you now, side by side with the ED, because the picture it paints is very different. And I think this is an actionable item and goes to the question of where does this data become actionable and how does it become actionable? There's an excessive mortality in Appalachian counties, and I would love to tell you that surveillance data tells us why that occurs. Surveillance data is good at the how, the where, the when, and the why is something that has to be left to other data sources. Two of our more timely data sets, which allows us to plan more timely interventions, is syndromic surveillance data. We receive that, actually we don't receive it, we actually log into the NSSP platform and are able to pull this data down. And this should match when we were to graph similarly the ED non-fatal overdoses, because this comes from the same data source. Basically, it's early messages of the admission to the emergency department is the initial message. There could be hundreds of messages for that patient that come in, but then they're condensed and collapsed. And we see this trend. The high point, of course, was May of 2020. Not surprising. We saw increased percentage of overdose involvement in the EDs because all other causes was declining during that time. But as you can see, it's visible to the eye that those non-fatal overdose visits are starting to decline. When we look at emergency medical services data, the top teal-colored line matches that emergency department, right? Because that's the transport. They pick them up, they take them to the ED. The red line at the bottom is when the patient is reversed in the field with naloxone, either by EMS, police officers, volunteer firemen, or a bystander, and they refuse transport. Without looking at this data, we are missing a significant portion of our opportunity to intervene because these patients don't make it to the emergency department for an ED-based intervention. So things like EMS interventions become more critical for these patients. I also want to, one half of our work is looking at prevention opportunities, and I want to highlight two of those. Find Help Now, KY, it looks at the distribution of our treatment facilities. One of the key pieces of that is it's not just counting the places that people could get treatment. When you search the website, you have the ability to tailor your search, but it also only returns facilities that have an availability. So that shortens the time period between seeking treatment and being able to find the available treatment. And as you can see, we have a pretty wide participation in our Find Help Now. Another sign of progress is the stand-up of the Find Recovery Housing Now. We only include certified recovery houses in this website, so we have some quality control over the quality of the houses that are depicted on this, and it has the same availability features that Find Help Now has. We are increasing capacity in our recovery beds, so we're excited about that progress. So just in summation, fatal and non-fatal overdoses have declined over the last couple of years, which is a positive thing. Unfortunately, it's disproportionately felt. We still have some work to do when it comes to Black Kentuckians, Hispanic Kentuckians, as well as different age groups and geographic areas. We do have publicly available data. That's what we do. And so this QR code will allow you to access our resource library for those data reports. And I'm required, since I'm CDC funded, to give you this, and I'm not going to say anything else about it. And then I'm going to turn it over to Dr. Rock. Okay, mouse.
Sorry, technical hiccup. Okay, I'm going to try to go quickly so we can still have time for questions. I know we have hopefully quite a few interesting ones to upcoming, but very briefly, this is another work that we're doing at UK. We're really fortunate that in Kentucky we have some of the best researchers and practitioners, working head on this opiate use disorder and opiate overdose. Particularly under this particular grant we call RADAR, which we spelled that way correctly. It's Rapid Actionable Data for Opiate Response in Kentucky. It's a large focus of trying to bring in some new data sets and some of those traditional data sets, get those in maybe a better visualized way on a dashboard for key specific stakeholders. We're also exploring some artificial intelligence and ways we can do maybe some forecasting. We'll touch on that at the end. Briefly to jump in here as fast as we can, this graph here demonstrates one of the key medications we use for opiate use disorder, or medications for opiate use disorder, MOUD, buprenorphine. This shows the counts with respect to two data sets, our CASPR data set and our Medicaid data set. CASPR is our prescription drug monitoring program, which is going to be monitoring all fills of controlled substances to Kentucky residents in Kentucky pharmacies. Similar to that, but a little different flavor here, is the Medicaid data that we present. Also buprenorphine fills, but in this case, we're looking at people with a diagnosis of opiate use disorder. We have a little bit more advantage to kind of dig into the data with Medicaid, and so it gives us a little more interesting understanding of what's happening. Both data sets are showing an increasing in buprenorphine over time. If we look at that, now that we know, like, as I discussed, the Medicaid data examines those with individuals with a diagnosis of opiate use disorder. We can see what kind of medications for opiate use disorder they're using. As we already saw on the last slide, the predominant one is buprenorphine. We also see methadone and naltrexone. Note that methadone was only approved in January 2019, so it's still pretty low. Just a note, I know we discussed rates here, and I don't know if everyone's familiar with rates. We're trying to just control for some noise that may happen when you have increases in populations. Specifically, since we're looking at people with opiate use disorder, we can also kind of look at this as actually a percentage. So what percentage of people with opiate use disorder are we getting medication to, at least among Medicaid beneficiaries? So when you're looking at buprenorphine, that's up at the 400 per 1,000, that'd be the equivalent of 40%. So you can kind of estimate what scale each of these medications are reaching in terms of the total individuals of opiate use disorder. Geographically, we see differences like we do with the ED data and the DEF data. Interestingly, we actually do a fairly decent job with respect to the Appalachia rural areas and our ability to get people on medications for opiate use disorder amongst our Medicaid population. So again, you can see that some of our highest proportions are in the 800s, or 80% of people with OUD that are on Medicaid are on a medication for opiate use disorder. We also have some data that we're looking at to kind of examine some of the increases in work that we've been doing for, or we in Kentucky have been doing for increasing pharmacy-based disposal take-back boxes, right? This is where you can return drugs that are no longer needed and trying to get opiates out of the system, right? As well as other medications. These are located within pharmacies. We have a very large geographic coverage. A lot of this work was part of the Healing Community Study, one of the many interventions and programs that they're working on there. Just to jump into this, we're taking, we're taking the EMS data that Dana had just presented and talked about. We're taking that weekly, because that's the frequency that we receive it on. We're geocoding that to little points on the map. We aggregate those all together, and we look at the last year of data every single week. We've developed a pipeline to do this. We use some kind of fancy techniques and statistics that tell us within a given area, is that area, based on all those points and all those EMS encounters, a hot spot? And then what does it look like for trend? Is it a new hot spot? Is it a place that's always been a hot spot that we're dealing with? Or is it maybe a little bit more variable? So maybe it's a hot spot one week and not the next. This is, we're hoping, gives us a really good granular view of what's happening in sub-county areas to really inform programmatic practice. The idea here is maybe this is what a a health department or a local health department could use for targeting naloxone box locations and other types of work at a very rapid level and a very specific level. And then to jump into the great world of machine learning, forecasting, artificial intelligence, kind of all in the same bucket there. What we're doing, again, is you've seen some of the data. We've presented a bit of it, but there is a whole bunch more. Lots of trend series of all types of information, from MOUD, overdoses, seizure data, what kind of toxicology is coming up in that information. And they're all trends, all describing different things that are happening. One of the things we can do with some of the latest and greatest artificial intelligence is called machine learning forecasting. So it's just a technique of having your output, and this graph is EMS overdoses, and we're putting in a bunch of predictors, things that we think may be related, and we let the algorithm determine what is going to be the best at predicting that. In this exact example, we use things even such as the monthly weather, like what type of climate is actually happening. We train it, which means we use the data from before that red line to teach the model for it to learn what is the best prediction. And then at that point, we stop it. The red line here represents the overdose prediction that it did, and then the blue line was the reality afterwards. They are pretty close, and that's promising that we can have something that can forecast out several weeks where we expect general trends to go. That's our hopeful goal. That's the work we're doing under this grant, is to try to find a way to get all of our data together in a way that may make us better understand or be able to help plan where we need to implement specific programs and where we may see overdoses changing. Yeah. And then, of course, my disclaimers. With it being an NIH grant, we are developing a public-facing website. It's going to take a little while before we have those things exactly aligned and ready to go. So that it really right now is a picture of a bunch of our very dedicated staff. So you can go look through those. I think it's questions.
Thank you very much. We appreciate that. That was very informative and very helpful. At this time, I'd like to open it up if there's any questions from any members of the commission.
I'll just make a brief comment. We really don't have a better partner than Kiprick. They do a lot of work with public health, with our office, with behavioral health. We get this same kind of update every month. It kind of keeps us on track of what we need to be doing. So thank you. Appreciate your presentation. Appreciate all the work that you do with us.
Thank you, sir. Anybody else? With that, thank you very much for your time. The presentation was very helpful and informative, and we greatly appreciate that. Thank you. With that, we're going to take a short recess. If we can have everybody back in at 10:35 so we can pick up with the next presentations. Thank you very much, and we're in recess. recognize that we have one member who shall be returning shortly, but we're going to go ahead and get started in the interest of time, so we will come out of recess. I want to thank our next presenter. I will read his bio and, to make sure everybody's clear. He's a nationally recognized expert. It's Captain Christopher Jones. Currently serves as director of the Center for Substance Abuse Prevention, CSAP, of the Substance Abuse and Mental Health Service Administration, SAMHSA. Captain Jones brings a wealth of experience to SAMHSA, having led substance use, mental health, and injury and prevention and violence prevention policy program and research activities for more than a decade. Prior to becoming director of CSAP, Captain Jones serves as director of the National Center for Injury Prevention and Control at the Center for Disease Control and Prevention. In this role, he provides scientific leadership and overall management of the center, including driving the center's strategic direction and advancing the center's priorities of preventing drug overdose, suicide, and adverse childhood experiences. Captain Jones, thank you very much for being with us today. We greatly appreciate this, and we recognize how busy you are, and thank you for taking the time to come join us.
Thank you very much. Appreciate the opportunity to be here. And in the 15 years I've been working on this, I have been to Kentucky many, many, many times and have worked with Van and Karen and others really to lift up the great work that has happened across Kentucky. And you heard statistics today, which I think paint a very challenging picture that the reality is we have a lot of work to do. But I think it's important to start off with the recognition that Kentucky has been a leader in this space. And things could have been a lot worse had those efforts not been in place. And I appreciate the opportunity to talk about prevention. There's obviously more than can be discussed in the time that I have, but I hope I can provide a good primer as you all are thinking about the dollars and the opportunity that come with the dollars to be invested in Kentucky, not forgetting about prevention. And there is an overall continuum of substance use that we follow within Health and Human Services and its HAMSA, primary prevention, harm reduction, treatment, and recovery support. And that primary prevention piece is an equal component of those other efforts. And much of the dollars that have come out from the federal government in recent years, as well as opioid settlement dollars, have been in other areas. And no doubt those are needed. Those investments are needed to address the acute urgency of rising overdose and people who are struggling with opioid use disorder and other substance use disorders. But if we don't invest in primary prevention, we will find ourselves not making the progress that we want to make. And here's just the latest data from CDC, again, to reflect that there is some progress that's being made, although I would say we have to be very cautious about celebrating that progress because we're in a very dynamic situation. The illicit drug market is hyper-local, it's very dynamic, and we have seen declines before that were erased fairly quickly when new synthetic opioids came into communities, carfentanil, nitazines, other emerging substances. So we want to continue to build on those successes, but you can see here that middle half of the country to the east have largely seen declines in the 12 months ending January 2024 to the 12 months compared to 12 months ending January 2023. But the western part of the U.S. continues to experience increases. And as our Kentucky colleagues presented on the previous panel, when you look in states, you also see that those declines are not evenly distributed, both geographically and socioeconomic demographic as well. I think the take-home point for me as we think about prevention and just the broader landscape is that we are definitely dealing with a very dynamic, risky drug market. Using drugs has never been riskier, whether it's somebody initiating substance use for the first time or somebody with a longstanding substance use disorder. The risk of harm for initiating or using substances is greater than it's ever been. And the Kentucky distribution of age groups for deaths, I think it masks a little bit. CDC typically cuts data 15 to 24-year-old, and that is a very wide-ranging age group, and the structures that 15, 16, 17-year-olds exist in is very different than adults. When you actually look at some of the recent data for 12 to 17-year-olds, you actually see continued increases in overdose deaths, and I think these are often people who are earlier in their substance use trajectories, and it really is a function of the toxicity. People getting counterfeit pills, they think they're taking their friend's OxyContin or Xanax, and it's actually pressed fentanyl. And it does challenge us to think about our prevention work in new and innovative ways. But the other part, as we think about prevention, is that the usual suspects are ever present, but also evolving. Alcohol, vaping, nicotine, cannabis. And this is typically where people initiate substance use. And some individuals will progress from there. So as we think about prevention, it's not a single substance approach. It really has to be looking at the shared risk and protective factors that can be leveraged to address substance use overall, which will have a benefit to addressing opioids specifically. And this is just latest data from SAMHSA looking at prevalence of substance use among 12 to 17-year-olds and then young adults 18 to 25. And as you can see here, alcohol, marijuana, other drugs are more commonly used than some of the drugs that are most commonly found in overdose deaths, like fentanyl, methamphetamine. And again, it just helps to underscore that polysubstance use is the norm. And as we think about prevention, we really do have to think about it in a broad way. The one slide I don't have here is the overlay of mental health with substance use. And we see whether it's kids or adults, people who are struggling with mental health challenges have higher prevalence or have higher use of substances. So to me, that's a real opportunity in prevention because we can address both mental health challenges and substance use by focusing on comprehensive prevention efforts. So as we think about prevention, and this will pull on some threads that were talked about earlier, that we really do have to think about upstream. What is it that happens in somebody's household, in their community, that contributes to risk for substance use? It doesn't just happen. Certainly, there are some people who, because of increased access and availability, will find their way to substances. But by and large, there are experiences that happen in someone's family as they're growing up or in their community that really is a very strong predictor of substance use risk. And we call those adverse childhood experiences. Some people might call that trauma. But essentially, these are potentially traumatic events that happen during childhood. And the more traditionally defined ACEs are things like physical, emotional, or sexual abuse, physical or emotional neglect, and then growing up in a household that has certain challenges like mental health challenges, substance use challenges, divorce, incarceration of a parent, or witnessing or experiencing domestic violence or intimate partner violence in the home. And when you look at studies, again, it is very consistent that kids who have these types of exposures have increased risk for substance use and overdose, in addition to increased risk for mental health challenges, as well as suicide and other leading causes of death as they become adults. It's important to note that this is not predetermined. People experience adversity, but they can overcome adversity. There are interventions, preventive interventions that can help mitigate the impacts of ACEs. But ultimately, from a prevention standpoint, knowing that these types of events are so connected to risk provides us an opportunity to think about how are we investing in prevention to address these key predictors. But we also know that the science on ACEs is very clear that there are other events that happen in somebody's life that play out very similarly to the more traditionally defined ACEs. So kids who are experiencing bullying, kids who are experiencing violence not only in their home, but in their community, violence at school, experiencing other instability in their life. So housing instability, job loss, very transient. They're not able to build connections or they're not exposed to sort of safe, stable, nurturing relationships and environments, play out very similarly physiologically to the more traditionally defined ACEs. And we know that social determinants of health are also can exacerbate or perpetuate the impacts of ACEs or trauma. So this is really thinking of root drivers in communities, access to education, housing, healthcare, transportation. How are we creating economic stability for individuals and families and communities? And then how are we looking at opportunities for connection in communities? And again, when you look at maybe a more traditional approach to looking at substance use risk factors at the individual level, at the relationship, at the community and societal level, you can see that ACEs are really sprinkled throughout all of those areas. And I think the take-home point here is that there are many opportunities with prevention to address holistically the risk and protective factors that play out across a community. And if you're only looking at individual-based programs, which is often where people think of prevention, we're doing a program with kids individually or in small groups, we're really missing key opportunities to advance prevention work. We have to think about how are we supporting parents, how are we building opportunities for connectedness in communities, and then really from a bigger P policy level, how are we thinking about the role of economic investments, strengthening economic supports for families. Now, that may not all fall within the purview of the Commission's dollars, but as you think about how best to invest those dollars, how do those Commission dollars go into support the broader activities that are happening in communities to address social determinants of health? I mean, I think Operation Unite is a good example just from my experience where, it started as a particular focus, but it really started to address issues of like jobs, economics, through other partnerships, through economic development in Eastern Kentucky communities, recognizing that critical role of jobs in supporting families on a positive trajectory. And the flip side of all of the risk is protective factors. So what do we need to do to address that risk? And I think, as was mentioned earlier around resilience, focusing on promoting positive situational, social, individual characteristics. So healthy development of social and emotional competencies, whether that's for kids, for parents, for families, presence of positive relationships. We know that even if kids have a really rough life at home, they're not getting their needs met, they're facing child maltreatment, having somebody else in their life that shows up in a consistent way, a teacher, preacher, coach, somebody else in their life that consistently says you are of value and provides that safe, stable environment can mitigate the negative impacts of what's happening at home. And then ultimately creating safe, protective, and equitable environments. And this is just to underscore the point around substance use and ACEs. The figure here pulls from the original ACEs studies, which were published in the late 1990s, where they ask adults, did you experience these particular events in your childhood? And then they ask them about their substance use patterns. And you can see that as people experience ACEs, in particular multiple ACEs, they are much more likely to report substance use. And really, however you cut it, you see the same relationship: smoking, alcohol use disorder, using illicit drugs, injecting drugs. Many other subsequent research papers show the same thing for opioids, whether it's prescription opioids or illicit opioids, cocaine or methamphetamine for stimulants. We see similar relationships. And in fact, we also see that people who experience ACEs are more likely to initiate substance use earlier. And this is important because we know the earlier somebody initiates substances, the more likely they are to develop a substance use disorder later in life. And I won't go into this, we could spend an hour talking about the underlying physiological manifestations of ACEs, but essentially it creates a toxic stress environment, especially in the early years of life when the brain is developing and the neural connections that help people process awards, process emotions, respond to stress are being made. And so this is really very early prevention activities to set individuals up on a healthy trajectory. And this is just a finer point on the social determinants of health. This was a recent paper that looked at county level social determinants and overdose rates at the county. And so again, the question was posed earlier about Eastern Kentucky and the disproportionate impact of overdose deaths, and the surveillance data can't answer the why, but certainly disinvestment, lack of opportunity has a contributing role. And these types of studies show that greater social vulnerability, greater crime in communities, lower income in communities, less access to healthcare, less access to housing are all linked to increases in overdose deaths. So it's not a theoretical thing. We actually can quantify that social determinants directly and indirectly contribute to risk for substance use and overdose. And I think for the purposes of the Commission's work and really thinking about the importance of the investment, you have hard decisions to make. You have to figure out across the behavioral health continuum, where do we invest our dollars? I would say that prevention has never been more important. Kentucky certainly is experiencing multi-generational impacts of substance use and loss to overdose. We did a recent paper that looked at the number of kids who've lost a parent to overdose over the last decade, and we estimated about 320,000 kids. We were not able to do state-by-state estimates, but no doubt, just based on my experience from engaging with folks in Kentucky, there are a lot of kids who are being raised by someone other than their parent. In some cases, that might be due to incarceration, but in other cases, it's due to death of parents from an overdose. And so I think these data underscore that if we don't invest in prevention, we're going to be playing catch up for a long time, because these kids, by definition, are going to have increased risk. It doesn't mean that they're going to end up using substances, but in the absence of prevention efforts, this is the next cohort of individuals who potentially will be struggling. And so there is an opportunity to invest dollars in supporting comprehensive prevention work. So what does it mean, practically speaking, to take our understanding of prevention science, of ACEs, of social determinants of health? How do you actually apply that from a policy, program, and practice standpoint? So at the individual level, on the left-hand side are the risk factors. On the right-hand side are different prevention strategies, typically more prevention programs that can be implemented in community or in schools to address many of the underlying individual level risk factors. So that could be things like life skills training, problem-solving skills, conflict resolution. There are a variety of evidence-based programs that can be implemented in communities and at the school level to address those particular risk factors. Again, this just is research to support the case that's being made. So this was a paper that looked at the influence of ACEs and protective factors on either substance use and or psychological distress. And they found that the factors that reduced risk were high resilience, family communication, school connectedness, having a peer role model, and a non-parental adult role model. Again, moving from theory to actual research to support why you would look at programs that do these things, because we know that they can mitigate the impacts of ACEs. Another program that's commonly used in the substance use space is the Strengthening Families program. This was a research paper that looked at the combination of strengthening families and life skills. So again, life skills is really helping kids to develop healthy and positive relationships, positive decision-making. This intervention was done in 7th grade with kids, and then a kid and parent intervention called Strengthening Families was done in 6th grade. This is randomized control research, so the best type of research you could do. They found that these kids who got their intervention in 6th and 7th grade when they were 12, 13 years old had reduced substance use even into early adulthood. In this particular paper, they looked at age 19. So again, you have made an investment in a prevention intervention that paid off. It reduce substance use. Other research using this same approach found reductions in opioid misuse up to the age of 26 from similar studies. So again, there are evidence-based preventive interventions that can be implemented to address individual level risk factors. At the relationship level, again, this really gets to the piece of who might influence young people or young adults. So parents, other caregivers, other adult role models in the community. So strengthening positive parenting, strengthening communication, setting boundaries with parents and kids, developing healthy relationship programs, both for kids, youth, as well as adults. And then, of course, if parents are struggling with substance use or mental health challenges, ensuring that treatment is available to support their recovery as well, because we know that there's a cyclical effect that if parents' needs are being met, then kids' needs are more likely to be met. So at this level, just an example of a program, Nurse Family Partnership. It's a home visitation program. And oftentimes this might be something that you would see more in the welfare context, welfare programming, or reducing child abuse and neglect, those types of things. But we actually know that it has benefits for substance use as well. So again, this is a very early program done in the first couple of years of life for parenting pregnant women and families. And nurse in this particular case works with the family to make sure that their healthcare needs are being met, that their social needs are being met, really trying to set parents up for success. I have an 11-year-old. When we were getting ready to have our child, I did not get the book on like how not to mess up your child. I did get a small pamphlet from our pediatrician, which was like how to change diapers and not kill your kid in the first 2 weeks, which I appreciated. But all of the other stuff, I'm just, as parents, we navigate it. And luckily, had means and support to be able to navigate those challenges. And the idea here is for individuals who need some additional levels of support, there is a program that people can do in the first couple of years of life. I think the take-home message for me is that when they followed these families out, you saw not only reduced rates of welfare need, criminal justice involvement, other government assistance involvement among the women who were pregnant and, raising an infant during the first 2 years of the intervention, but actually, when the kids were in adolescence, they found reduced substance use, better academic outcomes. So again, it just speaks to making those early investments in prevention can have a longer term payoff. Family Checkup is another evidence-based program that really supports parents and kids, and this is particularly looking at kids who are at higher risk. And again, it's looking at positive support for adolescents and positive parenting, setting limits and boundaries, parental monitoring, and then building that strong bond between parents and kids. And so again, other evaluations of these programs have found lasting benefits of the program. So again, another example of where investments could be made with prevention dollars. At the school and community level, again, now we're moving beyond the individual and family and really thinking about how are we changing the context that's playing out in communities? How are we creating opportunities for positive social involvement? How are we creating positive and supportive school environments? How are we ensuring that you don't have, a 9 or 11 month wait period for mental health counseling in schools, ensuring that people can get services that they need, but also raising awareness about the risks of substance use, scientific information about the dangers of counterfeit pills in communities, the risks of underage drinking, that they are seemingly inconsequential decisions to people who feel invincible, but may have long-lasting impacts. So just an example here, again, it's a school-based program that focuses on kids and parents, and it's a multi-component intervention. And I put this here again because I feel like sometimes we have to make prevention more tangible for people. It feels very squishy. So again, this is research that showed from the original studies that kids who were part of this intervention when they were in school had better outcomes on school misbehavior, lifetime violence, different measures of substance use and mental health, and employment and socioeconomic outcomes. This particular study actually went back to look at the offspring of the kids who got an intervention when they were in school. So the offspring did not get this intervention, but essentially their parents did when they were kids. And they found that those kids actually had continued better outcomes. And I think it speaks to the importance of investing in healthy trajectories for kids, youth who will become adults. And if we're reducing risk for substance use and mental health, there will be a more positive cycle that happens than what we often get where negative behaviors or potentially harmful behaviors are passed along to the next generation. Communities That Care is another community-wide prevention approach. Again, I'm not going to go through all the findings here, but just to say that when communities come together, and you heard this from folks earlier about sort of being very intentional, data-driven, really understanding what's going on in your community and using that information to invest in prevention programming, we see positive outcomes at the community level. And Communities That Care is sort of a vehicle in which to do that. And then the last area, really the bigger policy pieces. So this gets to the social determinants of health. How are we looking to strengthen economic, education, housing supports, addressing broader policy pieces in communities? If areas that have high levels of disinvestment and violence are the place where alcohol outlets are, vaping outlets, cannabis outlets, it is not a surprise that then you have challenges in those areas. And oftentimes that is very much connected to disparities and health equity as well. So this has to be a part of how people are thinking about the broader solution to addressing substance use and overdose. One study I'll just highlight here is a recent study from University of North Carolina researchers where they looked at the Supplemental Nutrition Assistance Program, and it's essentially flexibility in eligibility and its connection to state level rates of substance use and substance use disorder. And they found that those states that had greater flexibility with their SNAP programs had reduced rates of various substance use and substance use disorder outcomes. And again, I don't think most people would ever think of SNAP as a substance use prevention policy. But if you track back to ACEs, stress in a home, food insecurity, it's essentially how are we helping families meet their needs? And so this is a policy that is helping to do that. And it's not a far leap to understand then why it might help reduce substance use. There's other research that shows SNAP generosity and SNAP eligibility also can reduce child abuse and neglect. So again, another indirect way in which kids who are, getting physically abused, emotionally neglected, have higher rates of substance use or risk for substance use. So if we are reducing that, then the next step would be a potential payoff in substance use. So again, there is an opportunity to sort of widen the lens of what we think about from prevention. It's not just high school assemblies and we're telling kids drugs are bad. There is science to this. And we see at SAMHSA that, in fact, there are many communities that are ready to do prevention work. We don't have the funding to meet the need. Just as an example, we have a program that is essentially a program that builds capacity for prevention in states and in communities. And our community announcement this year, we had over 360 applications for funding, for 5 years of funding. We had enough funding to award roughly 40 awards. So these are communities that have said, we put a lot of thought into this, we're ready for action, but we don't have the resources. And I think this is where we can start to look at what block grant funding is coming. How is prevention money from the substance use block grant being used in Kentucky? Who has other discretionary prevention funding? And then who doesn't? And how do you use other infusion of dollars like settlement dollars to help meet those needs? Or communities who are already on the precipice of doing really great work, but they need some additional support to continue to amplify those efforts. So I think there are a lot of opportunities, and I hope that 5 or 10 years down the line, we'll look back and say that was a really important investment. We need to do all of the things to stop the bleeding, to address overdose and the urgency of overdose, but we need to equally do things to get upstream to address risk that's happening in communities. So thank you very much. Happy to take any questions.
Thank you very much, Captain Jones. That's very informative and very helpful. I recognize that you have some flight and travel things that we need to make sure that we get you out of here on time. But with that, I'd like to make sure if there's some questions from the commission.
Captain, thank you for your work. You seem to have a really good grasp of risk factors and skill development, and I'm thanking you have the infrastructure in place to maybe answer my question. But I'm curious, if we look at the states that have the lowest rate of death, what are they doing that makes them have the lowest rate of death? What age group have they identified? I asked this question to Mr. Lucas at the break, and he had some good points, and I'm curious if you could maybe, what are they doing in their court systems for treatment to help? What prevention methods are they using in the states that have the lowest rates, quite frankly, is my question.
Yeah, so I'll just go back to the CDC provisional data. So I think it's not a straightforward question because some states are dealing with increases, some states are dealing with declines, and even states that are dealing with declines, like Kentucky, are still high on the spectrum of rates. There are some states in the middle of the country that historically have had just much lower rates of overdose death. And if you look back historically at some of their substance use problems, it wasn't opioids. It was alcohol or methamphetamine in certain like Montana and other places. So for a long time, their baseline of overdose deaths was much smaller than Kentucky or West Virginia, where it was very much opioids, whether it was prescription opioids in the late 90s through mid 2000s, transition to heroin, transition to fentanyl. So it's difficult to have an apples to apples comparison across states because they're dealing with different baselines, they're dealing with different drug markets. But you can see here that some of those states who historically were somewhat protected from sort of a prescription opioid driven overdose death situation are now being impacted in ways that they never were because illicit fentanyl is showing up in methamphetamine or showing up in cocaine. So I think it's challenging to say that somehow Wyoming had all the right answers from a policy or program standpoint, simply because they had a lower overdose death rate. A lot of it was driven by just the baseline substance use patterns that were happening there. Whereas by the time Kentucky, West Virginia, Appalachian states started to recognize things, because at that time our mortality data were really lagged multiple years, sort of the cat was out of the bag in a sense. We had people who were addicted to opioids. There was definitely not enough treatment. There was not enough naloxone. And so there's still a lot of catch up that is still playing out today. So I don't have a great answer for you, but I think we do know from research that investing in prevention programs is important. Expanding access to medications for treatment of opioid use disorder is important. Expanding access to naloxone and overdose reversal agents is important. We continue to see, we just published a paper using data through the COVID period, where people who receive medications, methadone or buprenorphine, their odds of dying from an overdose in the year after a fatal overdose were reduced by about 50%. If you got a naloxone prescription, your odds of dying were reduced by about 30%. So we know that we need to invest in those. And I think that's where you're starting to see some progress, even in states with really high rates of overdose. They're starting to do those things, and they're starting to realize the benefits of doing it. I think my point is that is absolutely necessary, but we also have to invest in the prevention side as well.
Do you have time for one more
Sure.
question?
Well, it's always good to have you in Kentucky, Captain. It's always great to see you've been a wealth of resources throughout the years. I think it would be beneficial for this audience if you could explain how much money Kentucky gets for prevention and what perimeters you set from SAMHSA on how those dollars are spent.
Oh my gosh, I definitely do not have the exact number. I'm hoping that Van actually might have it, or Katie might have it. Katie is finding it out. So in the block grant is about $2 billion, and it covers prevention, treatment, and recovery. In the statute for the block grant, there's a 20% prevention set aside. So states have to spend at least 20% on primary prevention. So that could include universal prevention. Essentially, we're trying to shore up everybody's risk and protective factors, or it could be selected and indicated prevention, which is really trying to address higher populations at higher risk, or individuals who have initiated substance use but do not have a substance use disorder. So that 20% is about $400 million overall. So when you start to divvy that up by states, and it's based on population and other measures, it's not that much. And that is really the primary vehicle for supporting prevention in states. Our discretionary portfolio in prevention is about $136 million. And again, this is where we definitely do not have enough money for competitive grants to states or communities. The block grant is intended to be flexible. In the prevention dollars, we essentially lay out 6 different strategies, and that focuses on education and raising awareness, alternative activities for youth to not be involved in substances, all the way through more environmental design, policy strategies. It used to be that SAMHSA required states to invest in all 6 areas. We said you had to invest some money in each of the 6 areas. A couple of years ago, we issued new guidance to say you have to invest in at least one of the areas. And part of that was because some states may not need to invest in all 6. They may have general funds from the Assembly that could support that, or they have funds coming from different places. So we were trying to meet states where they are. From a research perspective, I'm interested to see how that policy has actually played out, because my biggest fear is that people will do the thing that's easiest, but not necessarily the thing that is most impactful. So we may look at that policy. That's what we're doing now to try to understand what states are spending on. The other thing I'll say about the block grant is that historically it has been like 80% has really been reserved for treatment and recovery, because there was no other funding for treatment and recovery. But now with Medicaid expansion, with parity, there is a greater coverage for people who have health insurance, whether it's public, employer sponsored. And so to me, that potentially frees up some of the block grant dollars. The 20% is not a ceiling, it's a floor. So states could choose to use more of their block grant money on prevention. State opioid response dollars are another large source, about $1.5 billion from SAMHSA. Prevention is a component in that. There is no specific set aside, but some states are using their SOAR dollars for prevention. The one thing about SOAR dollars is that they have to be spent specifically on opioids and or stimulants, whereas the block grant really is whatever substance use challenges are facing your state. And I'm hoping Katie has the number.
Not yet. But
Oh.
I said in the next 30 minutes.
Yeah. But again, there is definitely a gap between demand for prevention resources and what funding is coming out of the government. Like, although it seems like a lot of new money has come from Congress for substance use and mental health, our budget in CSAP has essentially been flat for the last 5 or 6 years.
Captain Jones, thank you very much. Like I said, I know that you have a flight to catch, and we appreciate you making the time and the commitment to come to be with us today. It's greatly appreciated, and it's been very informative for us. So with that, we say thank you very much and appreciation for your service.
Thanks.
Coming up next, actually, will be Dr. Catherine Marks, and we'll see if during that time frame, if she may get the statistics for us as we go through. Just as she's getting settled, I'll give a little bit of her background. Dr. Marks is a behavioral scientist with expertise in the intersectional, organizational, community, and policy factors underlying the opioid epidemic and recovery. As a project director for the Kentucky Opioid Response Effort, Dr. Marks leads the Department for Behavioral Health Development and Intellectual Disabilities, SAMHSA-funded state opioid response grant with the mission of increasing equitable access to high-quality, evidence-based prevention, harm reduction, treatment, and recovery support services throughout the Commonwealth. So with that, and Dr. Marks, we also want to thank you for the commission also to understand that she had travel issues and just basically came directly from the airport to be with us right now. We want to thank her for the dedication and being here. And with that, I'll turn it over to Dr. Marks for comments and presentation.
I sincerely appreciate that. It is so important that I was able to be in this room with you today to talk about what we've been doing with CORE and to situate that within what we've heard from the presenters before us. So grateful that we've had, especially Captain Jones, setting up such a nice background on prevention to talk about how we've invested with CORE. I want to say a few things really quickly. The first is that CORE is a grant. We call our state opioid response grant from SAMHSA the Kentucky Opioid Response Effort, but it's more than that. It's been the movement, it's been the collaboration and coordination that we've had at the state level since 2017 that's created an infrastructure for a larger response than even just the CORE dollars. And so you'll hear me periodically talk about how we braid in funding from other resources to be strategic, to maximize our reach, and to manage risk of duplication of effort. It has been an honor to transition into the role of Commissioner for the Department for Behavioral Health, Developmental, and Intellectual Disabilities a little over a year ago. But having spent 6 years as the project director for CORE, my heart is in this presentation. I think I might have jinxed myself by saying I could do this presentation in my sleep last night, as I'm turning out to be doing it half asleep this morning. So, but I just love this content. My background is experimental psychology, addiction research specifically. And so what I'm going to present to you today are both the approach, how we think about investing our CORE funding, and the specific programs that we invest in. But I want you to kind of just quickly understand where CORE, the grant, lives. It lives within our Cabinet for Health and Family Services, within the Department for Behavioral Health, Developmental, and Intellectual Disabilities. And it is in no single place. While it sits functionally in substance use disorders, we coordinate very closely with mental health and with developmental and intellectual disabilities. Our mission in this department is to increase access to services, improve the quality of services that individuals receive, and build an inclusive and resilient workforce so that we have that infrastructure for work. CORE, though, as I've said, is this collaborative effort. It crosses so many different state agency partners, our governor's office, obviously our Cabinet for Health and Family Services, representatives from public health, Medicaid, child welfare, OIG, our Justice and Public Safety Cabinet, Office of Drug Control Policy. I don't think we could possibly work closer with Van Ingram if we tried. Our corrections partners, our AOC, our universities and community partners. Everyone identifies themselves as CORE, and that has been the absolute strength of this resource. SAMHSA has been investing for since 2017. It's been a remarkable influx of resources that we've been able to distribute into the community over the years. We had the opportunity to submit the 5th round of funding just weeks ago, and are anticipating our what we call the SOR, State Opioid Response 4th grant, which is $37.2 million annually. I pulled up, I still don't have my block grant numbers. I'll never forget them after today. But in terms of the distribution of core funding, we distribute 5.5% of our resources to primary prevention, another 19% to harm reduction, 46% to treatment, and then 24% to recovery. So I love a good framework, and I'm a recovering academic person, so I have to kind of talk a little bit about how we approach our work in CORE. And so we use the Cascade of Care framework. This came out of an effective response to the HIV crisis, and what it says is, let's identify all the points along a continuum in which we would need to intervene with an individual to address the full continuum of experience, from preventing the initiation of use to preventing that transition to misuse, identifying treatment need as early as possible, providing treatment access and engaging individuals into care, and then retaining individuals in care. Sometimes we lumped treatment into a single moment, but it's so much of that outreach, engagement, and retention, and then sustaining long-term remission and recovery. And so a comprehensive response requires us to think about all of these components. Folks sometimes ask me, if we could only invest one place, prevention, treatment, or recovery, where would you go? There's no answer. We have to invest in the full continuum. But here's 2 really important concepts that have anchored CORE, is that we must reduce harm no matter where we are along the continuum of services, whether we are preventing misuse or whether we are sustaining long-term recovery. Just like we never stop buckling up our seatbelt after we become responsible drivers, we continue to invest in harm reduction services and supports and values across the continuum of care. And then building that personal, family, and community capital, that's another set of words to describe what Captain Jones talked about in terms of that environment and that community and the policies that we create that support protective factors and reduce risk factors, and that has to continue as well across the continuum. We also like to think about what it means to expand services, and so we have these guiding principles. It was interesting, we've actually drawn these from the World Health Organization, who was thinking about the right to clean and safe drinking water, but it applies really well, because what it says is that there's 4 things that need to be achieved in order to expand services in an effective way. So the first thing is obvious. They need to be available. The service needs to exist, right? But it doesn't really exist unless you can access it, unless you can arrive at the service that has been created for you. And we obviously see challenges in Kentucky with accessibility via transportation and rurality. But it can't just be available and accessible. Once you arrive at that service, it has to be the service that's right for you. It has to meet your needs, meet you where you're at. Otherwise, again, it's as if we had not built the service. And then once you're there and you're accessing that service, it has to be quality. It has to be evidence-based in order to change outcomes. And so those 4 criteria are all essential for how we think about growing and investing in services and programs throughout the state. Actually, let me just pause here for a second. I was thinking about what I would say, what are our quick lessons learned, because I'm going to transition very shortly to what we've invested in, what the state has invested in with CORE. But these are the things that came to mind. We have a lot of quality services and supports in Kentucky due to long-term investment from so many different fund sources. But what we struggle with is the idea of saturation, that there is a sufficient quantity of service, that everyone has access to it, whether it be treatment services or naloxone or recovery housing. And so continuing to grow what is working to reach all populations is valuable, and doing that has to come through collaboration and coordination. In that same vein, innovation is welcome, it's essential, but we have evidence-based practices that work that are not implemented everywhere. And so we have to invest in what we know is working in our communities while we also work towards innovation. And then a long lesson learned from us is that implementation of these services and supports is a process. It takes time to build the workforce and the training and to become sustainable and to deeply bury it into practices so that it remains long after we're gone. And so that implementation process takes time. And then the last is something that someone said to me recently. They said, we're investing in people because people are the intervention. With substance use disorders, it's individuals talking to individuals. It's people with lived experience engaging with other people. And so a lot of our resources and infrastructure go into investing in the people that then provide the services to other folks. CORE has identified 5 priority populations. We needed this to create some shape and form to where we would invest. This also, some of what I will talk about reflects what SAMHSA has asked us to think about in shaping our state opioid response grant. And so here's what we decided. We know that individuals who experience an overdose and survive are at highest risk for a subsequent overdose. And so any setting in which we encounter those individuals is the primary, most important individual to reach if we want to prevent future overdose. Pregnant and parenting individuals, we know, you've heard the intergenerational impact. They have to be a priority population. Individuals who are justice involved or criminal, legal involved, the reasons they're incarcerated are likely substance related. Their risk of overdose upon release are dramatically increased, and so we can have so much impact in this population. You heard earlier, I won't go any further into this for the sake of time, but Black, Indigenous, and people of color and the disparity that continues to grow in our state and transition age youth. All right, so I'm gonna move us through how we've invested in prevention and harm reduction and then to treatment and recovery. And I could spend hours on each of these programs. And so I wanna give you a flavor for some of the initiatives and services and supports that CORE is invested in, but I'll just highlight a few of these for us today. And what you'll see here, we like hexagons, but it really does capture the whole primary, secondary, and tertiary prevention as well as harm reduction in the array of strategies that we have invested in. And the first place I'll start is with our community mental health centers and their regional prevention centers. We have an existing infrastructure for community-driven prevention that is incredibly effective and really thinks about, you saw one of the final slides earlier, this individual plus relationship plus community plus society interaction. These regional prevention centers have the ability to grow community capacity for that primary prevention through mobilization and education and technical assistance, through implementing Generation RX, which is a well-established national campaign that we've brought to Kentucky to educate about safe opioid use, storage, and disposal, putting safe storage and disposal locations in communities, lock boxes in homes. They have the ability to see what a local community needs and respond to that. And then really importantly, 2 primary prevention in schools programs that we've invested in. One is Sources of Strength, and the second is Too Good for Drugs. These are K through 12 and also with after school opportunities to build up those protective factors and decrease those risk factors. We're in over 200 schools, and this is another story of saturation. We need to be in every last school with every last program. The second piece I'll talk about is overdose education and naloxone distribution. We like to pair these words together, overdose education and naloxone distribution, because both components are important. We know that this is such a vital strategy in reducing the risk of fatal overdose. And we've taken 3 key strategies to do OE&D or overdose education, naloxone distribution. And so the first is hand-to-hand, giving it to people who are most likely to experience or witness an overdose. The second one is equipping our pharmacies to be able to dispense on the spot. And the third is through co-prescribing. And all 3 of these strategies are necessary to fully reach every population and every risk level. But we know that individuals at most risk need that hand-to-hand. Here's your naloxone. How much do you need? With abundance, we will give you the quantity that you are looking for. We've leveraged the Kentucky Pharmacist Association, which has been really impactful for us because this is a braiding resources opportunity. We can take multiple funding sources, place it in one spot, and then they can distribute statewide. There's a website that anyone can go to and order naloxone for their community through this centralized website, and we continue to grow in the capacity. It's hard to keep up with the demand. It's beautiful to see that growth, but it does tick up every 3 months. We recently participated in a SAMHSA strategic planning session to develop a strategic plan for our naloxone distribution, and that was important. We're happy to share that in the future with you. I'll say that places that we still have so much opportunity for growth, and they'll reflect our priority populations, jails. That is a place where we do not have it in every jail for every individual at risk leaving. We need more EMS leave behind so that if an individual experiences an overdose or even just a complication, that they and the individuals around have access to it. And then our behavioral health providers as well. And so much room for growth here, but we have to use a variety of strategies to reach it. You heard about Find Help Now, KY, earlier. This suite of service locators is phenomenal. I'm so proud of what's been built in Kentucky. I wanted to put a quick plug for Find Naloxone Now Kentucky as well. This is built for people who use drugs to find where they access naloxone in their community. This is also a place you can see in the top right-hand corner, ordering for an agency. You can go to this location and have it shipped for free to your organization. All right, I'm going to start to move through some of the other places that we've invested in, and essential in this has been in our syringe service program expansion. We know that syringe service programs, they save lives, they reduce disease transmission, and they facilitate service access. And our investment in the local health departments has been phenomenal. Just in state fiscal year 2023, for example, 3,000 individuals accepted referral to treatment services that came to our SSPs. There were 36,000 individuals that participated in community events to learn about harm reduction, and 15,000 peer support service engagements. Syringe service programs are more than syringes. They're access to healthcare, they're access to dignity, they're access to resources that help individuals live healthier, more well lives. And so what we do is we create a funding opportunity and say we will award up to $15,000, for example, and all health departments can apply, and we go through a really simple application process, and then we award on an annual basis. Unshamed Kentucky has been another incredibly impactful strategy. This is a statewide anti-stigma campaign. If we could narrow down to the shortest list of reasons that hold Kentucky and this nation back in recovery, stigma is on the top 5. Stigma is so many different things. It's self-stigma, how you stigmatize yourself from what you've heard from communities. It's public stigma, how we respond to individuals who use drugs. It's stigma against medications for opioid use disorder, and it's also structural stigma, which are the ways that we limit people's opportunities to resources in our community. And so Unshamed Kentucky is a coalition of 78 community-based organizations that are telling their stories of hope, of recovery, of mothers, of children, of individuals who have found a journey towards wellness. It's incredibly impactful. On an average year, we get over 13 million impressions, 120,000 people directly engaging with the campaign. We have a fentanyl awareness campaign that's included in this, thanks to, again, braided funding with Office of Drug Control Policy. I would love to see this continue to grow. It's primarily delivered through social media, but there are more opportunities for in-person engagement as well. I'll quickly hit as the last point in the prevention and harm reduction space, what we call the Funding for Recovery, Equity, and Expansion, or FREE grants. When I looked over time at who receives funding from the state, oftentimes it's entities that are more well developed, that are more likely to have been established for years. And oftentimes that means that they are less diverse organizations who might be designed to serve a less diverse population. And so we've partnered with the Foundation for Healthy Kentucky to award grant funding specifically to BIPOC-led and BIPOC-serving organizations so that they can develop targeted outreach to BIPOC communities, equip individuals, communities to do their anti-stigma campaigns, our anti-stigma campaigns, harm reduction supplies. This is incredibly effective. We've leveraged multiple funding streams to do it, and we could grow this infinitely with more resources. So I'll move into the treatment stage again, and I'll remind us that it's not just a treatment program, but that outreach and engagement and access and then retention. Two major themes. I'll touch on medications for opioid use disorder, but the other piece is this peer support and recovery coach strategy. And so many of these you'll hear about how individuals with lived experience help people navigate through the system, through their own stages of change. And so I just wanted you to kind of listen for mentions of peer support or recovery coaches throughout these. You'll see so many different pieces I can't touch on. I'll just highlight that we're really excited to be growing, particularly into the child welfare involved youth space and co-occurring treatment. But I'll say it quickly. I know you've already heard it at least once before. Medications for opioid use disorder, they reduce opioid use and craving and return to use, risk of overdose and mortality, recidivism, and infectious disease, and they improve treatment retention and opportunity for choice and collaboration. And so what's essential for core grants is that MOUD is something that individuals can access. We're not saying everyone has to take a medication for an opioid use disorder. What we are saying is that everyone has a right to make the decision to access or remain on that medication. So here's one of the important strategies that we've leveraged, and it's been through our hospital service models to create a bridge to treatment. And we kind of have a number of different flavors from this, ranging from partnering with our university hospital hubs to higher volume and lower volume clinics to bridge navigators, just placing one peer support in a hospital. But the idea is that, as I said earlier, individuals who've experienced an overdose or opioid-related complication, they are at highest risk. And so when we change our model and when we treat overdose and withdrawal as a treatable medical emergency in our hospital and in our healthcare settings, we create opportunity for recovery. And that's a significant shift in how we've addressed overdose in our healthcare systems. And it's a simple, maybe 5-step process. First, we identify that what's presenting are related to an opioid use disorder. And then we treat that withdrawal with buprenorphine. It's very simple. We then bring peer support in, someone with lived experience to say, hey, I've been where you are and look at where I'm at now. Can we go along this journey together in a stigma-free environment? And then we link them to treatment, whatever level of care is appropriate for them. We are working to replicate that basic model statewide, but you see from this map, and this is 7 years in, that our reach is still woefully incomplete. And so the idea that we saturate our state with hospitals and clinics that have the ability to bridge to treatment is incredibly essential. Quick response teams is another significant investment that we've made over time. These are community-driven groups that provide assertive outreach to individuals who've experienced an overdose. And so sometimes people decline that ambulance ride to the hospital and we might miss an opportunity for engagement. So these are teams of peer support and clinicians and first responders who show up after the overdose non-judgmentally, non-coercively, and say, hey, we have that experience as well, and we want to help link you to treatment. They show up at homes, they show up in communities, they offer harm reduction if that's what they need, they offer treatment linkage. We are seeing rates of treatment acceptance from quick response teams exceeding 40% in some counties. These are individuals that would have never otherwise accessed services if we hadn't met them where they were at. What's also beautiful about these communities is they really know they know the topography, they know where the risk is, and so they are able to do follow-up, they are able to do naloxone box installation and target really specifically where it needs to be placed. Substance use disorder treatment within primary care is also so essential. We are so fortunate in the state to have grown into an abundance of residential treatment capacity and a payer benefit that supports that. But we still need to stimulate capacity for outpatient treatment, for recovery supports in that outpatient treatment. If we can use our primary care clinics to destigmatize that this is a medical condition that we can treat, to identify it earlier in the course, then we can have better outcomes, to keep people in their community with their families in employment, to treat their physical health conditions at the same time, we can really expand reach much faster. So we've partnered with the Kentucky Primary Care Association for them to then support their federally qualified health centers and rural health clinics to do that extra piece, to have peer support specialists on site and case managers to provide transportation to and from appointments, and then we support a community of practice that allows them to grow in the quality and fidelity of their work. Treatment access programs is another place that we've invested in. We have uninsured and underinsured individuals that struggle with access to life-saving interventions. And so getting individuals into residential levels of care and then retaining them into intensive outpatient who maybe do not have an insurance benefit that covers them, or maybe have Medicare, which doesn't cover residential in the same way. We have the ability to pay for treatment in those situations. We also have the same ability to do that with methadone treatment for individuals that lack a payer source. We partnered with Operation Unite for this work. We've been doing it for years, and the growth of that has also been exponential. It's allowed so many people not just to come into treatment that thought that they couldn't, but to stay in treatment longer. We extend care by an average of 47 days in IOP alone if individuals are able to access the program. All right, I'll move to the last phase, which is recovery. And we like to use the word recovery capital, and we think about this as the total resources that a person has available to them to sustain remission and long-term recovery. It's the same things that keep us here and working every day: our health, our economic stability, our stability in housing, our education, our transportation, and our connection to community members. And so we've invested in a wide array of recovery supports and services. But I want to emphasize really quickly the Access to Recovery program in reducing barriers to building recovery capital. We partner with FAHI, and what they do is they bring individuals in who are in early recovery that have low recovery capital. They lack many of these resources, and they say, we're going to pay for those things that you need. We're going to get you on your feet over this next 6 months. We're going to come up with a plan that's specific to your needs and your goals, and we're going to address your basic needs and your housing and your employment, your transportation, your childcare. This was based on a larger SAMHSA vision that they created years ago. We've braided funding to grow it as much as we can. Again, you see a picture of a state that's incomplete in access to the service. On average, individuals who participate in the Access to Recovery program come in with a recovery capital score that is under a benchmark, under a threshold that would say that they're likely to sustain remission for a year. Upon completion, almost everyone has exceeded that threshold that predicts likelihood of remaining in long-term recovery. Investing in jail reentry coordinators. We talked about this earlier, that this is such a high risk and high opportunity time to address both substance use disorder, opioid use disorder, and the social service barriers that everyone faces upon reentry. And so we funded, in partnership with Department of Corrections, individuals whose full-time job is to do reentry care coordination, specifically for individuals with opioid use disorder and stimulant use disorder. And I imagine Van will talk about the strategic initiative for transformational employment, but we've got a couple other strategies that we've partnered with Department of Corrections and employers to really expand opportunities for education, employment, and therefore economic stability. I'll finish in strategies with just noting the Kentucky Recovery Housing Network. What I've talked about is services and supports, but this is about infrastructure, and this is where our resources have been so vital. It's about the bedrock, the foundation under which other programs are successful. And so what this is, it's a standard for recovery residences, the National Alliance of Recovery Residents standard. Just July of this year, through legislation that we were grateful that passed, all recovery residences are required to be certified to this NAR standard that says that you are providing safe environments that are conducive to recovery. We are working to certify every last recovery residence in the state, and those that don't go through a certification process will be vulnerable to consequence. We want people in safe, quality housing. We have to direct them towards that through all of our resources, our carrots, and occasionally our sticks. We've also invested in recovery housing itself, but we still see a lack of diversity in the types of housing that exist. So people who are deaf and hard of hearing, people who are pregnant and parenting, people taking medications for opioid use disorder with physical disabilities or intellectual and developmental disabilities find it so difficult to find recovery housing in this space. So it's not just about increasing the number of houses, but increasing the diversity and quality of those houses. So I'll finish with just maybe restating a few things that are really important. It's a saturation of evidence-based practices that keep me up at night. How do we grow what is working? How do we continue to collaborate and coordinate to maximize those resources? And how do we continue to grow in implementation support, helping organizations get from A to B in their vision, which we share with them? Pieces that I wasn't able to hit on, but I just want to emphasize: individuals with co-occurring mental health and substance use disorders or opioid use disorders continue to be left behind. We have a lot of programs that say they're co-occurring capable, but they're not performing in that way. And as a result, we're seeing those individuals particularly show up in our jails, in our hospitals, in our state psychiatric hospitals, and without housing. And so that's a strong call for me as we move into this next grant cycle to support those individuals. And with that, I will finish and take questions. Thank you so much.
Thank you very much, Dr. Marks. We really appreciate that and providing such a wealth of knowledge and understanding on what's being supplied to the state. So thank you. With that,
I have a question. Yes, thank you. Thank you, Dr. Marks. I got really excited about this because there's hope here. When I see this kind of information, I really appreciate the work you do. And of course, my colleague to my right, your left. I have a question about the NAR certified housing. When I hear people in my community and other places talk about their sober living houses, I immediately think, are you NAR certified? And of course, I know that's probably not true, but is that possible for people to get the help and the education they need if they have a sober living house? Because I want to know who to plug them into.
Yes, absolutely. So what's beautiful about the Kentucky Recovery Housing Network, it's not just about going out and stamping people, you've passed, you failed. It is about technical assistance and helping people to understand what level of recovery housing they're providing and maybe to adjust to create something that fits a quality model. There's a website, the Kentucky Recovery Housing Network operates, and I'd be happy to pass that along and include it in a link in the PowerPoint.
Thank you.
Oh, I have an update as well on the block grant. So annually, we allocate 21% of our block grant funding to prevention. You heard Captain Jones say that the minimum was 20%, and that amounts to annually $4.4 million a year. 4.4 times 5.
Give us that figure again, that lump sum.
I'll give it specifically. It's $4,471,932, and that is 21% of the substance use block grant.
Mr. Chairman, I have a question. May I? Thank you. Dr. Marks, thank you so much. It's enlightening and it's encouraging. At the Treasury, we sponsor the Financial Empowerment Commission, and we are reaching into rehabs now. We find that many of the people that are there can't navigate financial anything, credit cards, debit cards, bank accounts, and illiteracy is one problem financial illiteracy is another problem. They may be able to read and write, but they just never had the exposure. And it goes back to what were called adverse childhood experiences, perhaps. They just didn't have good parents, perhaps, or no parents at all. And so I like what you're saying. What I would like to do is link some of my resources up with yours so that perhaps we can work together to assist each other. We are dedicated to making certain that not only our children learn something about financial impairment. Let me give you an example. We have children, high schoolers, running credit unions in Kentucky. They're sponsored by the Treasury, by the Financial Impairment Commission. And we'll give you a perfect example, one you can walk into today, Southern High School in Louisville. But I don't want to talk about our successes. I want to talk about our opportunities. I'd like to get some of my people linked up with your office so that you can talk about some joint efforts in terms of financial empowerment and reaching out to these unserved communities or these at-risk communities so that we're doing our best out of the Treasury to assist you in your missions.
That sounds wonderful. I can't help but just at least put an idea out there. I didn't talk about them, these spaces called recovery community centers, physical spaces where people walk in to access those recovery supports. Doing financial literacy and linking in those spaces would be phenomenal, but we will follow up. Thank you for saying this.
Thank you.
Any other questions? Seeing none, Dr. Marks, thank you very much for everything for today and for coming in directly in a timely fashion and doing that for us.
Thank you.
We appreciate that. Our next speaker is, I'm impressed, I didn't expect he was going to move from one chair to the other. But as you all know, we're honored and privileged to have one of our members be Director Van Ingram of the Kentucky Office of Drug Control Policy. And so as we focused on today, understanding the landscape from a larger perspective, but also understanding what it looks like in Kentucky, he's going to help identify and explain to the rest of us where some of the resources that he sees are going to, so it helps us to be informed about what kind of decisions we want to make. So Director/Commission Member Ingram, thank you very much.
Yeah. Well, am I not on? Okay. All right. So we give money to our Department of Public Advocacy for alternative sentencing workers. These folks work with defendants that maybe they have a drug issue, maybe they have a homeless issue, maybe there's something that's keeping them recycling into the criminal justice system. The alternative sentence workers try to dig down and find out what that is, and then be able to present to the prosecutor in lieu of jail, here's some other alternatives we can look at. So that program's been around for quite a while. I've testified in front of the legislature many times in support of it. And I think it saves counties and eventually the state a lot of money. By the same token, we give $2 million to the Prosecutor's Advisory Council for very similar positions, rocket docket positions, where prosecutors can work with public defenders and find alternatives other than often a felony conviction and work out an alternative sentence there. So we're happy to fund that as well. We also fund neonatal abstinence syndrome centers. So you heard earlier about pregnant and parenting women with an opioid use disorder being a priority population. We have a number of programs around this state that do amazing work taking care of pregnant and parenting women with an opioid use disorder and their children. Some of the grants that we've given recently have been about keeping moms a little longer. After they've delivered, let's not throw them out with the wolves. Let's keep them a little longer, keep them close, and get them the services that they need. We also give money to our community mental health centers. We have 14 community mental health centers around the state. We generally get grant applications from about 10 of them. And we've done things like quick response teams. We've done recovery housing. This commission may remember transportation was an issue we heard about everywhere we went. Well, sometimes transportation issues can be solved by bringing the services to the person. So some of our community mental health centers are doing mobile services that we have helped fund. So every year we work with them. We're also required to give money to the Department of Corrections. We have 76 full-service jails in Kentucky that house our Class D inmates. Only 23 of those jails actually have a substance abuse program. I'm hopeful before I hang it up that we have a plan to have this in all 76 of our jails. It seems to me that those people with Class D sentences could be the ones that would benefit most from services, but are offered the least. Another program we do with the Department of Corrections involves transportation. If someone on probation or parole has a really difficult time making it to a treatment appointment, has a really difficult time making it to the probation office for a meeting, for a check-in, we've offered up some money to use Medicaid non-medical emergency transport drivers to also take around these folks that are on probation and parole. When I talk to probation and parole officers and ask what are the biggest gaps in service, it's always transportation. People have a hard time getting where they need to go. Getting out of prison, and often you don't have a driver's license, don't have stable transportation, and as we know in many of our rural areas, there aren't many options. We also pay for the Unite Call Center, 8338 KY Help. I used to get so aggravated, I'd watch TV and there'd be somebody in a lab coat with a stethoscope saying, call this number and we'll help you with treatment. Well, that works really well if you have insurance. If you don't, they're going to hang up on you pretty quick. The statewide call center that we fund is operated by Operation Unite in Prestonsburg. Quality people, licensed social workers, compassionate folks that know how to talk to people with a substance use disorder or their family members and help them find and identify the help they need. We got about 4,000 calls last year into that line. Another 15,000 outgoing calls because we check up on everybody that calls in. We follow up with everybody. You heard about the Kentucky Pharmacists Association and how we use them for naloxone distribution. I set aside money every year for any law enforcement agency that wants naloxone that can't afford it, we'll pay for it for them. We also provide to the Kentucky State Police enough to provide all their troopers with naloxone. We give some money to the Kentucky Medical Examiners Association, or Medical Examiners Office, for some more in-depth testing and identifying substances that are maybe new or developing in fatal overdoses. We fund a Recovery Ready Communities program. Volunteers of America Mid-States, we pay them to help us with this program. Right now we have 14 communities that have been identified as Recovery Ready. Next month we hope to identify another 3 or 4 more that'll become Recovery Ready. And this has just been a phenomenal program. Representative Bowling sponsored this legislation, signed into law by Governor Beshear a few years ago. Communities don't get anything. They don't get a tax break. They don't get anything for doing this other than the bragging rights of saying, we have examined our community. We're doing the things necessary to become a recovery ready or recovery friendly community. And I'm really, really proud of that, of the work that we've done there. I mentioned we give funds to Kentucky State Police, not just for naloxone, but for some highway interdiction programs, as well as education and prevention programs that they do as well. We also have a program with the Kentucky Chamber Foundation. We heard earlier the importance of jobs for folks in recovery. The Chamber has a unique way of reaching businesses that I don't have. I've been collecting a government paycheck since I was 19 years old. I don't know a lot about the private sector, can't go into too many businesses and tell them how to run things. But the Chamber does. They have those relationships. So we pay for a Fair Chance Academy 3 times a year. They bring employers in and show them the benefits and the policies and procedures they need to have in place to give people in recovery a second or third or fourth chance, whatever's necessary. I also have funding with the Kentucky Broadcasters Association, where we advertise the Find Help Now, KY.org website, as well as the 8338 KY Help. Dr. Marks mentioned SITE, the Strategic Initiative for Transformational Employment. Our partner there is EKSEP, the Eastern Kentucky Concentrated Employment Program. And we have somebody located at all of our career centers in Kentucky whose main job is to link people in recovery with jobs. So one day they may be out recruiting jobs in their community. The next day they're meeting with clients and trying to link those two together based on the skill set or that person brings to the table. We've used some federal funds the last 2 years. We're doing it now, and we've got another federal grant pending to provide naloxone to anybody who's leaving a jail or prison that wants it. We know we don't always reach the right people. I've carried naloxone since 2015. I go out to eat one night a week and I'm home in time for Jeopardy. So I'm not running across too many people. I'm not the best guy to be carrying it. We need it in the hands of people who are more likely to encounter a drug overdose. And I think criminal justice involved is a good way to do that. So last year we partnered with 39 jails and prisons and put out about 13,000 dosage units of naloxone. Our goal for this year is 50,000, work with 50 jails and prisons and double the amount of naloxone we put out. So we've asked the Department of Justice for $1.4 million in a grant to do that, and we will hope to hear back soon on that. Finally, let me say when Dr. Quisenberry was going through her presentation and she indicated there was an increase in people 0 to 4, babies, overdosing, the look on Karen's face was priceless because she was shocked that could happen. But it does, and it's happened way too often anymore. So we've been given funding for the last few years in partnership with the Child Fatality and Near Fatality Review Committee. For folks that they have medications in the house that are legitimate medications, we'll pay for a box, a lockbox to keep it in. So it's to reduce the ability of a child maybe running across that medication. So that's kind of an overview of things that ODCP is funding presently. We do some one-offs every now and then, fund something just one time or something temporarily to fill a gap. All of our funding is approved by our Kentucky State ASAP Board, as well as the Cabinet Secretary for the Justice Public Safety Cabinet. Chris, I told you I'd keep you at 12 o'clock. I think I got you there, buddy.
That you did. Thank you. Is there any questions or comments from any members?
I would just call that a poisoning and not an overdose.
That's correct. Thank you, Karen.
Anything else from any of the members?
What's your funding cycle? Or does it vary?
So we're funded on a 2-year budget that the General Assembly passes on even-numbered years.
I do have one question, especially as we still have Dr. Marks in the room also, but I'm just curious as between the two of you having the breadth of what is funded through state vehicles and processes, is there an area that you all see, especially understanding what the commission can fund, where you have difficulties in filling that gap in terms of a funding?
I'm going to invite Dr. Marks to come back up, and while I mention a couple of things. You saw the reentry coordinator map. My comment to Karen as we sat there was that map needs to be filled in statewide. Everybody needs those services. Dr. Marks talked about recovery-ready communities, recovery community centers, I'm sorry. Those have proven to be really effective where we have them at helping people stay in recovery. We just don't have enough of them. And I'll stop there and let you go ahead.
Yeah, maybe I'll try with a mic on for this last piece. I thought about this a little bit beforehand as well, and I think Van's comments are spot on. In earlier comments, we have a fairly robust treatment reimbursement structure. Where we struggle is in kind of right before treatment and after treatment. So outreach and engagement, finding people in the community and engaging them into services. So things like quick response teams and mobile outreach into the community need to grow dramatically. And then on the recovery support side, stable housing, continuing to develop
Transportation.
education, workforce, and transportation. I would say number one barrier people describe when we go around to listening sessions in the states. One thing that we have as a limitation of federal funding is that we can't pay for renovations to spaces. We struggle with paying for rent, and certainly new builds are impossible for us. And so we have a number of entities that say this way we can be sustainable if you'll help us get into the space we need. So I would say that that's a common gap. Also, paying for nutrition and food is often a common gap that our federal resources can't support. But when you're trying to engage an individual into care, and maybe they haven't slept well in weeks or months and haven't had a nutritious meal, the ability to pair food with other resources and services is really valuable. And then recovery community centers. People in recovery are driving the change in our state. And if we could have a community center, a recovery community center, a space where people come together and support each other in every county, that I think would dramatically change our landscape.
Thank you very much. It's very helpful. Like I said, having both of you at this forum at this time, it's an opportunity I didn't want to miss. So thank you very much. With that, is there any other matters from anybody before we take a recess? Oh, thank you. One of the things to make sure also is that we had announced, and at the podium there was an opportunity for public comments. At this time, no one had signed up, but I want to make sure, as we have the opportunity, if there is anybody in the room who we missed because they didn't recognize or didn't realize they needed to sign in, I'd like to open that opportunity up right now. All right. Seeing, oh, wait, we do have someone. Oh, okay. Excuse me. Give turn the mic. Yes, please have a seat, and we'll take a moment. Thank you.
I'm not microphone operatable person.
There you go. We have you now. Thank you.
Hi. So I'm Dr. Kay Combs, and I represent all the people that you all are serving across the state of Kentucky. I'm out in the field every day. 95% of the people that we serve in adult education have a substance abuse problem or a mental health problem. And I just wanted to say that the services that you're providing across the state are remarkable. I will say that there is such a huge need for transportation. Some of the things that we cannot provide are transportation and childcare. We're moving into the family literacy component of adult education because it is essential that we provide a multi-generational change, and we do not have the funding for that. But the parents that we see, you said children 0 to 4, there are so many small children impacted before they go to preschool, but we're seeing their parents. And we are also dealing with people who are on probation and parole that are court ordered. There are so many instances, and they come in and they don't have food. They do not have clothing. They do not have a place to stay. And so we're the front operators. You talked about financial literacy. Adult education programs offer financial literacy. All of our services are free to all the individuals that you serve. We do need more support at the state level for what we do and offer for our individuals that you serve, because education's the key piece. And I hope that you all understand that, of course, we do have adult ed in a different cabinet and providing services, but we need the support continued to partner. So when you said there's career services in all the communities, I will tell you that there are several communities I work with. You cannot find a career services person available. You can contact them. I can tell you that you can walk into an adult ed program and we provide those career services without a career counselor. So there are many things going on that I know that you believe may be going on in the field, but aren't actually available to the participants that are walking on the streets that are homeless. And I see that every single day walking across and through the counties that I serve. So I hope that you will continue to look at these areas of need and please be mindful of those. Thank you so much.
Thank you. And Ms. Holmes, if we're able to, if you can get with the staff and make sure we can get your information for the record, just so we have that and able to get your name and proper name and contact information. So thank you very much. With that, is there anyone else in the room? Thank you very much. With this, we actually are on track and on schedule. We're going to go ahead and take a recess until 12:40, and then we'll come back in, gather, and be able to move forward with the rest of the program in the afternoon. So with that, we're in recess. Okay. So is it streaming? No, I understand that. I just didn't. All right. Everybody, thank you very much. We're coming out of a recess and we'll begin to pick up the proceedings again and to move forward. Thank you. Thank you, everybody. I'll repeat that as I neglected rule number 1. I asked to remind everybody to turn on their mics before speaking, and I just neglected that. So as a reminder for everybody else, especially as we go through the sessions that we're about to go through and the conversations, please make sure to activate your mic and to speak into it. We want to make sure to record it. As we've talked about, we're going to go through starting that process. Again, and this won't be the only time we do this, but to begin the level setting, the groundwork for priorities for this body and having that discussion. What I really want to do is move through 3 questions to get a sense of where you all stand. And after each individual goes through a little bit, if there are any questions or somebody needs clarity, feel free to ask that, or if staff who's going to be recording this has a question or wasn't clear on something, they may just ask you to repeat or to clarify something as we go through. Again, we want to make sure that we take into consideration the commission members' knowledge, experience, and what you've seen through this process already to make sure to define some priorities that look like what the commission feels the priorities should be of the commission. So we will go through with some guided questions. I think you all have probably seen some information to help you think about this a little bit. But what I'll do is literally work from the left. We'll go through the first question through everybody, and then we'll come back through and hit the second and third. We should be able to move forward with this. And again, if there will be other opportunities for us to continue to have these discussions, but we'll get started with the process with that. And with that, I will start with our newest member, but the first question that I'd like for the commission members to take up is, what are your top priorities for the next funding round? We've given them broad categories that we've looked at in terms of treatment, prevention, recovery, but you may have some more specific things that you think that you'd like to make sure that the commission take a look at. So, Mr. Fugit, with you, I'll start with you on that.
Thank you, Mr. Chairman. So, and again, I don't know how much you want me to talk on this. Just my, my experience as a trooper, drug detective, and then I've pastored the church for almost 13 years there in Hazard. And probably one of the biggest things that I've seen is when they get out of jail, when they get out of treatment, where am I going to work at? So one of our, our county judge, and maybe this is a program that's going on all over the state, but our county judge, in conjunction with Hazard Community and Technical College, have started a program where after the technical college is finished for the day, they take inmates from the jail, and they're getting carpentry certifications from HCTC, the technical college. They've had 29 men and that have graduated, and probably most of those 29 were in jail because of some type of drug-related offense. Most people are. And so I think if we had more educational opportunities for them, it doesn't just mean book learning, but a trade that they can get out and go to work with a certification. It'd be a lot easier to find a job. Even in the mountains, there's a shortage of, people who can build plumbing and different things. So I talked to our judge just by text a few minutes ago, and he said it cost him about $20,000 to put those guys through that program. And so I don't know if that's something that we could look at across the state. Maybe it's already being done.
How much did you say?
He said $20,000. And I don't know if that includes the entire 29, the group of 29. Yeah. But if you've got 29 men and you invest $20,000, that's not a lot of money for them to come out of vocational school with a certificate of trade. So I think that would be a good thing to look at. Of course, housing is a big issue back home too, but I think that educational opportunities keep them busy, keep them out of trouble, and that may be something that we would look at.
Thank you. One of the things I recognize and appreciate that. Before we move on to the next, I want to recognize that we do have Commissioner Freeman with us virtually. So I want to go to her to make sure we don't get through this process and realize that we haven't gotten to Commissioner Freeman. So I want to make sure we get to you right now.
So thank you, and I appreciate it. I'm sorry that I'm not there in person. But, you know, I mean, I think we heard really a lot about prevention today, and Captain Jones, you know, really gave us some good information and a lot to think about. So I think clearly some of the things also that Dr. Marks brought up in terms of, you know, recovery centers. So, I mean, I think there's just lots of opportunity for us to think about what we heard today and how that might fit in with our priorities.
Thank you. Commissioner Allen?
Just most anyone that knows me here in the short time I've been in this seat, I'm a prevention advocate. And I would just like to know that, and we can probably debate and decide what age group, but I would just like to know that every school in Kentucky, public and private alone, has some type of education curriculum toward prevention. And I know I'm a big advocate of Unite. I'm proud to say that I work for them. We identified 7th and 10th grade. Unfortunately, folks, these little contraptions right here cause kids to grow up at a much faster rate than even what we grew up. So I don't know if 7th grade, honestly, is the target group. So maybe we sit down and identify that. But I would like to know, before I'm done here, when that may be, that we have every school in the state is working toward because it just doesn't happen now. For a while we did DARE. I know Unite does in the 5th district, but I'd like to see a statewide initiative for curriculum and prevention. I'm a big advocate of that, and I'll take this a step further, and maybe this is something that the Republican legislature can take up. But I would like to know the curriculum. I just don't want some kind of gobbledygook thrown out there to these folks. I would like to know the curriculum, what's being taught. I grew up in a kind of I was poor. We grew up in a trailer. I'm an only child. My dad was a binge drinker. And Saturday night I would hide from my dad because if he found me, he'd beat me up. But my daddy found Jesus and he changed his life, and that forever changed my life. So I'm a big proponent of faith-based, specifically Jesus Christ and the Bible. And I know that's probably not welcome in these halls, but I'm going to say it anyway. I would like to know that the curriculum is faith-based, and so maybe that's something that the legislature can take up. That's probably a tall order, but that would be my number one initiative and goal for myself and my perspective. Thank you.
Thank you. Dr. Oh, yes.
Do you want our overall priorities or just what focused on, like I'm looking at the first question, do you just want our recovery priorities or are you talking about overall? Because I was taking it page by page, but I'm not sure I think I'm wrong.
Right. So nobody's wrong, but at this point, we're looking for what your overall priorities are in terms of if there are additional things within that, then that can be identified and clarified. I think those were examples to go through. It may be, you know, prevention, and as talked about, in school-based prevention may be the priority, or maybe something in the recovery field as we're talking about workforce training and development. So it can be one of those others. But if you have multiple to need to be through, we're not trying to prohibit anybody from expressing more than one thing. We're just trying to get that initial conversation to figure out where people are at.
Are you going around again for a second round, or just should I speak until I'm finished?
If you've got,
I've got one other thing, and it wasn't to credit to this folks today that presented to us. I think we need to take a look at transportation. That's probably had 6 or 8 speakers today, and I think 6 of them referenced transportation. So I don't know if we changed our bylaws and the way we look at purchase of vehicles. I don't know. That's you folks got more experience with that than I do, but we probably do need to take a look at transport, and that's more of the treatment side of things, but definitely take a look at transportation. Thank you. Sorry to interrupt again.
No, thank you. And that's one of the things is, we didn't specifically say do or don't with certain items because we wanted to hear your voices and where you think that needs to be and goes through. So thank you again. Like I said, we want to hear those opinions and those thoughts. We don't think this process had taken place in this way before. So I want to make sure not to remove anything out. Again, with the mics. Dr. Roop?
Well, there's been a lot of good information that's been shared here today, and a lot of helpful information. And I think when it comes to prevention, like my colleague had mentioned over here, I think, you know, the DARE program worked for me. I never touched a drug or a drink, drank a drop of alcohol all through school. But when I left school and went to college, that's when I began experimenting. And then I fell into a path of 17 years of active addiction. And so I think when we're talking about prevention, I think bringing the focus away from the external decision-making process down to, and it's been shared here earlier, the cultivation of resiliency, how to navigate difficult emotions, conflict resolution, building healthy relationships. I think the curriculum, you're exactly right. But I think it needs to do more to help our youth to cultivate their identity, to know who they are. Because when you know who you are, you'll know what to do. And for me, I forgot everything after I graduated high school, and so most everything anyway. So that's in the area of prevention. I think that's really good and will be impactful. When it comes to recovery, I think, you know, obviously the evidence-based modalities and efforts are very much valid and worthwhile. And I would like to see, I think we're really kind of still revolving around the symptoms, and we're not really getting down to causality. And I think as we roll out additional programming and evidence-based programming, I think one of the things to look at, you know, making sure that organizations are ensuring that their clients have proper aftercare, you know, access to medication after they leave treatment. And we all know this, that's a big gap currently. So I think there's some things that we can do as a commission to kind of help oversee that quality or that continuum of care post or departure from the treatment centers. And then also in conjunction with the MAT, some type of psychotherapy that gets down to the causality. Because honestly, and I'm just speaking from lived experience, we're not comfortable with negative emotions. Hardly anybody is. We don't know how to sit with difficult emotions, and what we tend to do is we want to escape that discomfort, and we escape through drugs and alcohol typically. So if we can get down to that root, if we can get down to the causality, to how we deal with negative emotions, I think we'll make a lot of traction. So, yeah.
Thank you, Ms. Butcher.
Well, I like what you said, Jason. You go deeper and a different way, and thank you for expressing that, because I could not do that nearly as well as you did. And that's, I think, the problem I've had with the medication, Suboxone, whatever you want to call it. I always say it wrong, but you all know the generality of that is we give it out, we give it out, we give it out. I'm not saying it's not important, it is. But, and then what are we doing also alongside of that? I don't want to just keep tossing out like candy and then not getting to the root cause. But in answering this question here, I took this literally to mean what were our top 2 priorities in each of these categories. So housing and transportation. And yes, I think we do need to change what we limit or allow with our funding around transportation. And then for treatment, and this is really hard to narrow this down to 2, I said the co-occurring health disorders and the pregnant or parenting families even. I wish we had family living houses. And then on prevention, you know, this starts at preschool. This doesn't start 7th grade or 6th grade. We start resiliency building and who am I and how do I handle emotions at preschool. So I don't understand, and Dr. Marks showed this, that the 2 things they have been using that are evidence-based are sources of strength and too good for drugs. And so why can't this be something that we do all across the state for that one? And then, there's so much, you all, that it's very hard to prioritize, very hard. Next.
Just to go on Karen's comments, that Too Good for Drugs and Sources of Strength is offered to every school. We have about 200 schools that have taken it up on that offer, but it's offered statewide to pay for the curriculum. The school then has to find somebody to teach it, of course. Yes. But yeah, that's available, and it's Too Good for Drugs is a good program. I started that when I was a police chief. We use that. in Mason County. So it's a good program. It's evidence-based. It's been around a long time. Sources of Strength really doesn't deal just with substance use, but about decision-making and the things Jason was talking about. You know, my highest priority is recovery supports, and that can be a lot of things. That can be transportation. That can be education. It can be locating a job. It can be I've got a job, but I don't have the right clothes to wear. I got a job, but they want me to bring my own tools, and I don't have any. So we've set aside some money with our program that I talked about with EKSEP to help people with those things. But whether it's employment, whether it's transportation, whether it's housing, all of those things I think are important. We know that relapse is a big deal. A lot of people go through treatment many times. But the longer we can keep them in treatment, the longer we can keep them engaged, those chances of relapse are reduced. And a good job can take care of those problems of transportation and housing. And so if we fix that one, that can fix several others. So I'll stop there. I got more to say about prevention and other things as we go on. But Dr. Marks said it, we have a really robust treatment benefit in Medicaid. In our treatment and recovery committee, we got a lot of applications to expand residential treatment. Well, that's really not a need. We have all the residential treatment in Kentucky. We have more per capita than any state in the country. So we need to, in my mind, we need to focus on where our needs are and not where they're not.
Thank you. Go ahead, Ms. Birdie.
Oh, okay. Well, I grapple with a lot of this. I think a lot of great things have been said, and I agree with Van on if you could just start. I think with when I did recovery, I just put support groups, and all of those things fall under support. Because we didn't mention the need for expungements, because if you come out of prison and you don't have your record expunged, you can't get the job. You can't move on to the other things that you need to do. So if we take a look at it, I think we need to look at all of those items that stops one person from getting a job. I mean, there are organizations like Dress for Success and, you know, other organizations that provide services. So to me, it would be support groups. To put those different, to get certifications in areas if people want them. The question that we grapple with is maybe we don't know all the organizations. Maybe people don't have access to all the state opportunities. Maybe that money runs out. So when we start looking at what's in Louisville now, it's that Goodwill Opportunity Center, which is a great option nowadays because under one roof, they have everything you all just mentioned. So I think if we do start looking at the all holistic approach to getting someone back up on their feet, recovery, etc., I think Goodwill does everything but the treatment piece. But they do have all of that. So I think if we do start looking at grants, we should make sure we don't do duplication of services if at all possible, but we do look to support as many people as we can. So that would be my one thing under a lot of different categories. My concern also is the mental health piece. What do we do about that, and to make sure we're partnering with the right people? Because that's a big piece of a lot of it. Mental health can lead you to use drugs. Mental health can lead you to be homeless because you're on the streets, because you can't get a job. None of the things are falling together. So we have a lot of people who are falling in the cracks that are walking the streets of all of our towns and communities because they don't have these services. So I don't know what the solution is for that, but maybe we look at a way to stand it up stronger by use of everybody who comes and puts forth a grant. And as far as prevention, I think everything can be linked, like he said, to reduction of adverse childhood experiences and risks. I come from my parents divorced when I was 12 years old. I have two sisters, but we all made it to college. We didn't use, but my father was an alcoholic, so there was a high potential for us too. But thankfully, through church and God, we did not turn to alcohol or pregnancy. We made it out because my mom was very strong to put these in us. But there are people who don't because of so many other distractions and things that you can do instead of us just going to the library, which my mom pushed us to the library and church. So everybody does not have, they don't have, we have to understand that people don't have the same support systems. And we tend to look at these and we judge because we're in the position to judge. But we also have to understand that everybody doesn't have some of the support. So if we can get down to the reduction of adverse child experiences by looking at some of the things in the school-based systems, whether it comes to creating a program that touches all the school systems, like Too Good for Drugs or whatever it is, we need to be more aware that these services might be available to stem the tide. And I want to say, because if we touch the schools, we can touch all diverse levels. We can touch all students from whatever backgrounds, from whatever areas. And if we lead with the schools, we can get them when they're younger and maybe fend off and prevent some of this. So those are my areas.
Thank you, Ms. Kelly.
I think about my time at Unite, and I think about having a conversation with Katina Hayes, who's the director of the Boys and Girls Club in Harlan County. And I will never forget one of my first visits there. She looked at me and said, "We've started grief counseling programs here because in 1 6-week period, 13 kids that come to this club lost a parent, and 6 of those kids lost both parents." I met a young lady who crawled up into her father's lap knowing something was wrong with him and stayed there until he died. We've got to provide hope for kids that are struggling with the loss of a parent. And we heard Captain Jones and we heard Dr. Marks talk about the importance of reaching those kids. I lost my dad when I was 16, and it was really hard. But he wasn't an addict. God provided me with the best dad imaginable for 16 years. And I felt really sorry for myself until I walked into Camp Unite and met all the kids who've never had that. So our Boys and Girls Clubs, our schools, our churches, it is incumbent upon all of us to let those kids grieve, but not grieve without hope. There's a difference. I've been there. So I think, Kentucky's one of just a few states that didn't have a center for grieving children, and we do now. But there's 2 people there trying to do all this work. So I think those are the things we need to take a look at. What infrastructure's in place that we could just provide a little bit of a resource to and reach a lot of kids that are being impacted day after day. I think that's probably at the top of my list because I know what these kids are going through. And you talk about coping mechanisms and anger problems and anxiety. And, if somebody is there, if somebody's there to teach them, to let them know that it's all going to be okay, I think that's going to be the difference maker in their lives. And we can be talking to their kids in 25 years. And be saying and tell them, and hear them say, life is different for me because somebody intervened. I knew they cared. And I think there's training and things that the schools can do. And there's, I think, probably some volunteer organizations willing to do that. But I just think that it's so important we don't lose the sight of the next generation. That is true prevention. My number 2 would be workforce. Again, it's like grieving without hope. If you don't have a job, what do you have to get up to go to the next day, to feed your child, to figure out how to pay the rent? In full disclosure, by all the statistics, I should probably potentially be on a government checkup a holler somewhere. But Congressman Rogers gave me opportunity I didn't know existed. And truly believed in me when I didn't believe in myself, and said, you can come work here, but you're going to finish your education and you're going to show up every day and you're going to shower before you come to work. And these are the things you're going to do. and I don't want any excuses. And there's times in our lives we all need that. We need somebody to give us opportunity, but also not accept excuses. So I think a job and coping mechanisms are the two most important things we can do to help those that need it most.
Thank you. Mr. Secretary?
Amen. Particular, Jason, I appreciate you thinking about prevention in the way that's like, let's get to the root cause of this, right? We're going to have too many people getting in this bad stream unless we figure out how to stop them from getting it, how to stop them from getting in the ocean, right? Whatever all those analogies are. So obviously, you know, I always think about prevention, right? It could be substance use. It could be child abuse. It could be a lot of things that we see, right? Homelessness, right? All of that stuff. It all comes down to, often comes down to, it's not always, because they're great parents, right? With great housing and great support. And sometimes folks end up in a bad place. It happens, right? But where you have that impact, and again, in schools, absolutely, right? We know that. And there are evidence-based pieces that show that. So long way of saying prevention is what I think about, and what I hope that we can do together. And then that recovery support, right? On the other end of whatever we want to say, whether it's getting into a doctor's office and getting Suboxone, whether it's going through residential treatment, whether it's coming out of incarceration, right? What's that support, right, that keeps you from going back in all those cases? And so I again, that's the kind of stuff I because of where I am, right? That's what I'm going to think about. And how do we support people? Who said hope? To let that hope in, right? How do you support that? That's jobs, having a job that you want to go to, that maybe you feel you can support a family on, or at least yourself. And obviously, every time we went out, with this group went out across the state, we always heard transportation. And oftentimes we heard housing and all of that stuff. But here's where I'm going to make a little cut. Right, some of these programs exist, right? Whether we can support them or not, but some of these programs exist. Like, what does this money need to do? Which is a slightly different answer. Which is then I really think about, I don't know how to say this, infrastructure, right? How do we connect programs and people to get them to the support? Some of that support's out there, but how do we get them there, right? How do we get them to the Goodwill, right? Right? How do we make sure that they get where they need to go when they're coming out of corrections, right? They're doing a lot of work, but obviously we can do more, right? Somebody identifies a kid in school that's got a problem, right? Before my team gets involved, because nobody wants my team involved. Before my team gets involved, how do we get that kid to services, right? So it's a long way of saying that, but making sure we can make those connections, I think that's probably the most important thing we can do. Thanks.
Thank you, Mr. Chairman. I had the benefit of listening to everybody, so it reminded me of a few things that are important to me, and I haven't done much plagiarizing. So as a local prosecutor and as an assistant Commonwealth attorney, and I prosecuted federally for a while, I got to see at the federal level alien smuggling and people being used as mules to bring drugs across the border. But at home, I got to see the effects of those drugs reaching our localities. And I think this is one of the great generational challenges of our time. I'm so glad you put this together. You and the Attorney General, I'm glad to be sitting next to Dr. Friedlander and all the other members of this panel. All of us who've had direct contact in some way or another with this terrible problem, and it's a scourge. I believe prevention is the key, and I believe education should start in kindergarten or first grade. When I was prosecuting as county attorney, we weren't prosecuting the drug traffickers. We were sending them on to circuit court to be handled. We were dealing with the possessors. And what did we do with those people? After we got the Medicaid dollars, after we got ARC, after we got Isaiah House, we were sending these folks where they belonged, to a drug rehab. I agree that faith-based is the best because it offers hope beyond the borders of a rehab, beyond the physical borders of a rehab. That's how Jason Roop and I got to know each other, through a local effort to oppose the efforts of traffickers, for lack of a better expression. But what we discovered in my last 7 years in office was that local effort of parents and teachers and schools and churches, law enforcement, and prosecutors and judges. We learned that we could make a difference if we combined our efforts to really push back hard against what we saw happening. I carried my best friend, one of my best friends from high school, to his grave. My brother carried his brother to his grave. And the same man who I carried to his grave had a son that I prosecuted. So it is generational. But I think we go to prosecution. We put the traffickers behind bars. And I believe in effective prosecution that sends a message to anybody else who thinks they're going to try to do this in our communities. We send the users and the possessors on to rehab, and we have to get used to the fact that some people need 10,000 second chances. But we have to hold everybody accountable. And we did that through drug testing, and we did that through depriving men and women of their children. If you can't get off drugs and raise your children, we'll have your children raised someplace else. And we're doing that in Kentucky, in every family court across the state. I shared this with the panel one day, that one of the best things that the ideas that I heard coming out of Tennessee, and I think Dr. Friedlander told me that you all were using this at least on an experimental basis, was to say through our judges, when we brought moms in who were testing positive for illicit substances, we said, you get to keep your child when that child is born if you'll enter into a program whereby we test you weekly to see if you're not using. And that was the best incentive. It worked in Tennessee. It was about 90% effective because moms then realized that they could keep their babies if they would agree to get off drugs. And so they had to make a choice. Is my child more important to me than my drugs? But I think we need to adopt it into our code through CHFS or through a regulatory measure. The other thing that I noted is that at UK Med and at U of L Med, the costs every year for children born addicted to drugs exceeded $20 million in each hospital. So if you attack the problem of mom being on drugs, then you attack the problem of the child being born addicted. So if we can speak as one voice as a panel, we could start making some recommendations that I think might get the attention of law enforcement, prosecutors, judges, and hopefully the media, so that we can actually lift these issues to their proper elevation in terms of importance. Last thing I wanted to say, and I heard this said in so many, using this word, but also other words, it's a holistic approach. One of the things we encounter in the Treasury through our financial empowerment is plenty of people who can't open up a bank account. They don't know what a credit card or they don't know the difference between a credit card and a debit card. So helping people navigate these kinds of issues while they're in recovery, I think will be one of the added benefits of the work we're doing. If we can drive these kinds of lessons home. When you were presiding at one of our meetings, and we were considering a grant that had been put forth by the public advocacy groups and legal aid, that they would help people get rid of their expunge their criminal convictions, help them find transportation to and from class or perhaps to job interviews. And we approved that. We approved that grant because we felt that it, on an experimental basis, it might yield some very positive benefits. And I believe that is one thing, not one thing, but a program, that program being offered by the Legal Aid Society, and I cannot remember the particular grant, but we can look it up, offered the kinds of benefits that we're looking to not so much endorse until we've seen how effective it is. But I like the idea of being willing to experiment on the front end in order to get potentially positive benefits on the back end. I didn't come in here, I only came here with one fixed bearing, and that was do the best I could. And that's what I hear everybody doing. We sit down at a table to discuss the grants we're looking at. We have some very vigorous debates, but we all leave the table as friends. So I think that we've accomplished one thing already, and that is we're all, pulling in the same direction. But the other thing we can do, I think, is you asked for my priorities: prevention, prosecution, but also rehab, and the holistic recovery approach to treatment. If we can do that, I think we will have far exceeded anyone's expectations for us.
Thank you very much. I appreciate that. To close a little before we go to the next question, just to make sure I comment on this also, I think one of the things is clearly we've all been listening to hearing the same things in various ways, because for me, that recovery piece and the prevention piece are the two that stand out. The one little twist that I want to make sure gets kind of highlighted in terms of recovery is that recovery support also including families of those who go through the trauma. And so for me, that's one of the things that I'd like to make sure that we don't lose sight of in this quest to make this process better. So that's the one piece I'd like to add, but I thank you all for that.
I want to make a comment, and maybe I don't need to, but it'll make me feel better. Is that all right?
Yes.
Thank you. I think we need to be careful about separating treatment and recovery. I remember the Attorney General talking about a three-legged stool. I'm going to say it's a chair, because we forget that treatment is not recovery. It's not synonymous. Recovery support goes on and on and on. I think we're talking about it, but I don't know if we're sure to differentiate it. I'd like for us to do that.
Thank you. To keep
Can I ask a question about that, just for the notes? Karen, when you talk about that, are you suggesting they be two separate categories?
Yes, I am.
Okay, thank you.
You all good? Okay. Thank you. Right. To move to the next question that goes through, and Dr. Freeman, we'll start with you again, making sure we're going through. But what do we want to touch on was when reviewing grant applications, what do you think should be priority considerations on whether something is funded? And so just again, some of the type of things that one would consider might be geographic region, or are there collaborative efforts, the economics of things, are there startups or innovations? What do we look at those things? But we'd like to get some thoughts from you all in terms of what types of things in that nature or criteria are something that should also be considered. Regardless of what category it is in, what are some things that you would look to see or like to see as it relates to consideration for those things? And I'm not sure if we lost Dr. Freeman or not. Okay. We'll work to that. There you go. Well, I'll tell you what. We'll go back through and pick up again, and just keep moving. When Dr. Freeman joins us again, we'll
All right.
revisit that.
Thank you, Mr. Chairman. I think that, you know, I think that the biggest consideration should be if you are dealing with a group, different groups of people that are willing to work together to get something done. You know, I think that's the biggest thing. If you have churches and schools and you have recovery centers and they're all working together, you know, because as my buddy Foote said, you know, churches need to be a big part of that. And if you got grant funding that's going out and you've got a large group of people willing to work together and hold each other's arms up and hands up, I think that should be the best. If you've got people working against each other just for notoriety or something, I'm you know, I don't think that would be good. But when people work together, we get a lot done.
Thank you, Mr. Allen.
I certainly won't be as long as I were the last time, but collaboration is good, to echo his sentiments. And I think workforce, anything we can do, and that's already been highlighted, but anything we can do to help folks have a purpose to get up every day. But I really don't have a lot to add. I'm still learning. I was kind of came in at the busiest time, and Jesse's smiling at me because she knows I ask a lot of dumb questions, but still learning myself as to what we can do, what our you know, what's the best way that we can help the folks that we serve. So I'm glad to be here. I'm a little charismatic sometimes. I don't want to come across as a know-it-all, because I'm not, but I tend to look at things what worked for me. And I know what worked for me. I came honestly before Dare, and Nancy Reagan probably, I give credit to her for just say no, and I could say no, but I just really want. I'm disappointed, honestly, and I'll say this to Van's point, that there's 200 schools. Why aren't all the rest involved in some type of initiative? Where's the pressure from the KEA to make sure that they add this to the curriculum box of things that's checked when they leave grade school? So I can't think of anything that's been more drastically affected our citizenry than this. And if we know that prevention helps, and I think we all would agree that prevention helps, then why isn't a grade identified in a curriculum put in our schools, public and private? Thank you, Mr. Chairman.
Thank you, Dr. Roop.
That's a good question. As I was kind of looking into prevention, I was surprised to find out that since DARE was rolled out, the rates of addiction have risen 400% in this country. And the founder of DARE was quoted as saying in front of a Senate Judiciary Committee in 1990, Daryl Gates, that casual drug users need to be taken out and shot. Now, like I said earlier, DARE worked for me, and it's worked for a lot of people, and it's done a lot of good. But I think that this idea of it's us and them, and anything that's fear-based or fear-driven cannot promote lasting change. And so this requires all of us to take a good look inside and to determine, like, is it really, are we more closely associated with those who are struggling in our communities? Or do our communities just have these nuisances that need to be dealt with? And I think what we're getting at there is an entire outlook and perspective that is, it needs a bit of nurturing in terms of like how we collaborate from the religious perspective, from the educational perspective, in terms of like community businesses allowing people into recovery to have second, third, and fourth, and 10,000th chances. And so I think really when it comes to prevention and recovery, like this, the fear-based initiatives really may, and I'm not saying they do, but it may, and according to the evidence that addiction rates have risen 400%, like it may do a little bit more damage than good. And so therefore, anything that seeks to bring together diversity, that seeks to offer those second chances, those levels of assistance that encourage people and give people not only an opportunity, but dignity, self-respect, hope, and purpose, and empowerment. And we ought to be at the cutting edge of that here in Kentucky. I mean, the fact that I belong on this commission is a credit to the grace that God flows throughout this state in terms of like me having this opportunity. And so I think that just needs to be reflected in our communities. And back to your question, Chris, like I think that it requires some hard introspection that, we all just need to look. And again, I do say DARE really did help me, but I was shocked when I just looked at the evidence. Addiction rates have risen 400% since introduction of it.
Nothing but respect for you, but I kind of disagree. I think fear is a good motivator. We just view that differently.
Yeah.
I don't, we cannot have a civilized society if there's not some aspect of fear. Fear you're going to get caught for speeding. Fear you're going to get caught for running red lights. So fear is not such a bad thing.
I agree. It's not a bad thing.
I just would.
Yeah.
I think we
agree.
just disagree in that, but all due respect for you.
And all due respect to you, yeah.
Well, I want to make sure we keep the focus on those pieces of it in terms of what we're looking at in terms of, priority considerations for the funding. Is it really those things? Is that a collaboration piece that I'm hearing from you, Jason, in terms of what that looks like? I understand there's lots of other pieces, but again, I use the example of geographic region or underserved communities or things of that nature. And so I want to make sure we pull that focus out from what you're saying. And I'm not sure if it's just a collaboration piece or if there's more to it than what you're saying. That.
Yeah, I think it is. It's the collaboration piece in terms of cross-agency cooperation, collaboration to share resources.
Okay.
Well, my two, first, the startups and the innovation. I fought for a lot of those on our committee, and a lot of times they didn't pass. And sometimes with good reason, and I respect everything that Van and all of the other committee members know and the knowledge, but especially Van, because you've disseminated so much and you've worked in this field for so long with giving monies. So I would like to see us consider more. And so that, in addition to the collaboration, because that's a big thing we do with the Leadership Kentucky program, a great program. By the way, the Appalachian people, young professionals, are in that program. And so one of those people who graduated from the program last year, Dr. Sidney Whitaker, is in Letcher County. And I was invited to go to a rally that they had called Recovery Central Celebration. And they have an organization where their community stakeholders have come together. Are any of you familiar with this in Whitesburg? Called Help End Addiction for Life. Not to be confused with, first I did, what goes on at UK with the HEAL study. Help End Addiction for Life. And at first I didn't want to go. I'd been in Indianapolis. I'd been driving for 2 days. And I thought, oh, please. And I went. And just like this room, I sat in an auditorium at Letcher Central for the first half of the day, freezing to death. And finally I left. But let me just tell you what I experienced that afternoon. They had a march. The majority of the people in the march started at one end of Main Street, and then we went to the old Whitesburg High School, and we walked up those stairs. And so I asked Sydney just afterwards, because, I was just absolutely humbled. I was blessed by being there, and I just said, how many people were in the march? There were at least 400 in the march. And then how many meals were served at a place that we turned down because it was innovative, called Kane Kitchen. And what I experienced at Kane Kitchen, and Weta Michael, who owns many, many restaurants here, she was there helping them cook and has helped them. I'm sure you know about that. They served over 500 meals in that Kane Kitchen. Just then, when I was there with them. They gave out 500 boxes of Narcan, 40 records were expunged, and they also had educational things. Now, I say all that to say those people in Letcher County came together in spite of and because of all the things that are stacked against them. And now I'm so sorry that we did not support that startup. But you see, I wouldn't have known all that had I not gone and visited. And it wasn't an official visit. It ended up being one because I was like, wow, all these things were going off in my head. And one of the things they've done in that kitchen is they've come up with their own line of products called Mountain Legend. And I'm not giving this to you because I tasted it and it's the bomb. It's called Hot Honey. And you can put it on your chicken or your waffles or whatever, but it's honey and it's real spicy. But I just want to tell you, good stuff is happening out there with or without us. However, it will not be sustained if we don't give this money to people who are doing the work and need the money. Case closed.
Thank you. Director Ingram?
Well, certainly there are things that I look at for funding, whether it's something from ODCP or from this commission. One of the things that Karen always brings up that I think is very important is partnerships. It goes back to collaboration. Who are they working with? If you're not working with anybody else in the community, we're missing out. We have deserts in Kentucky where very little is going on. So I always look at see the service gaps. Are they there? Karen and I have been back and forth on innovation and startups. I'm going to go ahead and explain my philosophy that this is not my money, so I can't gamble with it. I tend to lean towards funding things that have a good track record with handling government money. I would like to see us in the future set aside a portion and say, we'll spend up to this much for something that's brand new. But I can't support giving $500,000 to something I never heard of before with money that's not mine to spend. So that's been my struggle, and we've been back and forth on it. And then lastly, one of the things I always look at is, this is in Franklin County. Well, Franklin County's got this much opioid abatement money. What are they doing with their money? Before you ask the state portion to fund something in Frankfurt, what is Franklin County and the city of Frankfurt spending their opioid abatement money on? And so I always look at that as well. So they're just some of the things that I always consider with every application.
Thank you. We have Commissioner Freeman back on with us, so I want to make sure that we pull you into this conversation. I'm not sure if you heard the first part of the question or what that was.
I think I have gotten it from listening to other folks. And before Van spoke about the deserts, that's exactly, the thing that was in my mind in response to this as a priority is really, understanding across the state, we have places where there's high burden, but not a lot of services. And so how do we make certain as we're, considering our funding priorities that we're really, reaching those areas where there's gaps, as Van said. And then I'm a strong proponent of thinking about how we make certain that we are equitably reaching people. And I don't know, the majority of you probably don't know this, but I have 3 children and my 2 sons are deaf. And here with cochlear implants, but so I have, a lot of experience growing, with the boys growing up and, accessing services for them and the challenges that they have faced over the course of their, since they were born. So I think we really have to make certain that we're considering our underserved groups, and that we are, trying as best as we can to be equitable in reaching everyone who is impacted by this horrible addiction.
Thank you. Appreciate that. Ms. Purdy?
Karen, that's a good segue for me because I feel the same way. We need to make sure, irregardless of the community, the region, to make sure across the state we're being equitable to everyone. So I wanted to put that on the record too. That was one of my priorities. And then one of the things I thought, I also agree with Van on the startups piece of setting aside maybe something for the small ones versus, I mean, because we had a lot of proposals that came before us where people were brand new, had no background, no track records, no nothing. So I think as a commission, we need to take a look and make sure we're doing good work and diligent work with the people's money. So I'm about that as well. And then finally, I want us to consider going forward whether we will keep funding the same people year after year after year, or if there should be a gap. If someone just got $1 million from us this year, should they get $1 million again from us next year? Same for $500,000 this year. Do they get $500,000 next year? So I want us to put that in front of us and really look at spreading the money to more grassroots organizations, or if we want to take a chance on some startups, but we don't keep giving the same people the same amount of money. But if we do decide that we are still great on Unite or whoever's doing great work, we insist on some greater collaboration, so the money is still spreading out a little bit better to smaller groups. So that's what I really feel that we should do.
I think that we have to consider, is it the community that's applying for the funds, or is it some outside organization that's come trying to save us from ourselves? I've heard from a lot of those groups, and I think that we just need to make sure that whoever we fund has community buy-in and is a part of that particular community that they're serving. As far as Unite or funding groups over and over, I think it's a matter of educating ourselves on, is the money spent properly, and is it making an impact, and are they doing good work, and is it the community, and do they have partnerships? I feel like Unite can check all those boxes, but I think it's up to them to come to the table and tell us that. I think we've got to ask the tough questions of people who've received the funding and make sure that, we want to continue those efforts. But I don't want to penalize somebody because they're doing great work and just throw out a grant application because they got money previously. I think that's wrong.
Thank you, Secretary.
Lots of folks have said this, so I'll try to be quick on the repeat. If people aren't working together at the local level, then you already got starting 3 steps behind, right? If they're fighting, I always like to say when we're working with children's services, right? It's all about the kids. It's all about the kids. It's all about the kids until it's about the money, right? So just making sure that folks know at the local level, that's our expectation, that they should be working across systems and across systems, across service providers. Absolutely. Karen, I have some feelings similar to Van, but I also have some feelings really in your, right? Innovation is where breakthrough occurs, right? It's where that occurs. And so some of those small little guys, right? Some of those little kitchens, right, that we don't think of sometimes, they're the ones that make the innovations. They're the ones that, or they're so close to the street. And remember, I did some homeless work, right? They're so close to the street. They're the ones that do the right outreach. So having some having some pot of funds for that kind of innovation makes all the sense in the world to me, right? And just a little bit where we say, hey, we're going to take a couple little chances here, right? We're going to take a few chances here. I agree with that. And then you all have said it so well. I think it is a good discussion to have about how long do we fund somebody. There's 10 years of this funding. I'm losing count. 9, 8, 12. If we don't, there is probably longer than a year or 2 of a run out. But what is it, right? And then and as long as we're clear about it and what those expectations are, and here's how we're talking about it, so we can be clear with the folks who are putting grant applications and they don't get surprised when they put them in, then I think that's fair.
I mean, I apply for a Gaines Foundation every other year.
Yeah.
If I could get Gaines $2 million every year, I'd take it.
Yeah.
But they spread it out and say, if you applied this year you got to wait until the next year. Depends on the amount of money and all of that. So I just think we need to think about those.
I think that's a really legitimate thing for. I echo that is something that we really probably should try to figure out together, right? What makes sense for us, last, and I think that this is just data driven. If we're talking about evidence based and data driven, you know, I'm in that camp. Hooray! We've had a couple of years where we're seeing overdose deaths go down. We're seeing near fatalities. You know, which if they weren't matching, if those trends weren't matching, I'd be worried, right? But they seem to be matching. 2 years is a start, but that's all it is. That's all it is. We're not there, right? But the other thing that we're seeing is, are there counties where it's increasing, and are there populations where it's increasing? And we see that the evidence is out there for us to see it. All right, let's target there too, right? So it's just, if we're going to be evidence based, we've got evidence out there. That was a great presentation. Let's follow it. All right, that's it.
Thank you. Mr. Metcalf?
Chairman, I get back on. I like Vaughn's point that you made. You were concerned when we were considering applications that people might be using us to basically turn in the same application and without showing us outcomes. And I agree with you. I think we need to insist on seeing outcomes that merit the money we're putting behind these applications. And we discussed doing that, is making that a part of the application, that they understood we have to see outcomes. And Karen's point, continuing the successful applications, I think is putting these on a continuum so that we can see progress from year to year. I think that's a valid point, and I think Operation Unite has proven its value over the years. Long before I sat down at this table, I was monitoring them from Garrett County. Of course, Rockcastle was one county over, and we were seeing great results in Rockcastle County. So, and now Unite is covering Garrett County, which is a great thing for Garrett County. But the last point I wanted to make was when we do collaboration, I look for these grants to produce involvement from the schools, from churches, law enforcement, political leadership, and the medicine and nursing side. And we were able to do that in Garrett County, and I'm not saying that we deserve a pat on the back. I'm not saying that at all. But the effect of it was that we had a former principal who was then an assistant superintendent at the Garrett schools, and we got them to put anti-drug education into the curriculum. Now, I think that you have to scale everything based upon how old the child is and how mature the child would be. But I think one of the good things we can do, or some of the great recommendations that could come out of this commission, is that we insist that we bring in our churches, we bring in law enforcement, we bring in prosecution and judges and the schools, the KEA, and we, have them in the audience, have them at the hearing table, and tell them that we believe that if Kentucky's going to win this fight, we have to bring all the resources of Kentucky to bear. And if we do that, I think we'll have some results we'll be proud of. One of the things we were able to do, and this was quite by happenstance, I just tried to get people who were leaders in Garrett County together and get them seated at the same table. So we were able to talk through the problems. And we had two moms who had lost sons at the table. And they were able to share their stories and bond in these meetings. And their bonding revealed to us just how acute these problems were. So I think, Mr. Chairman, we have some great opportunities here to bring Kentucky together in some very material respects and be a critical agent for change during the life of this commission. And I feel lucky to be sitting where I'm sitting today.
Thank you very much. Very much appreciate it. Again, as I did the last time, I'll take the last stab at this, but I think the two things that stand out to me are things, which have been reiterated by this group, but it is collaboration or partnerships, which I think has been a better term to really utilize that, is how are you connected with the community and what does that partnership look like? If you're an organization getting money from us based on this, I'd like to know that you are partnering with others to expand your reach. And then the other thing, which I said from the first day when I came on, that I'd like to see that the money serves all the communities, and I recognize that is there's a varying need and there's different resources, and how you get to that point where resources need to go to the right places, where somebody has resources and somebody else doesn't. I'd like to be able to see us support those who are in need a little more than others, but I recognize that is a hard ask and a hard place to get to just based on the information. With that, we've got one other question, and I am going to this time start on to my right, or to the audience's left, to make sure that you all aren't at the end all the time. And this question is going to be, what restrictions on fundings would you like to consider? And again, I think part of the process is that for those who've been through the grant process and going through the applications, that there are a lot that come through. There may be some that you see and say, hey, this is, although the work may be good work and do quality things in a community, this might not be the vehicle for which they should be funded, or the way that goes through, or this process, there are the things they're asking for. And so we'd like to get a little help on things that you all think are things that we should consider, potentially limiting or have questions on. But with that, I'll turn it back to you, Mr. Treasury.
Thank you, Mr. Chairman. I refer to Vaughn's statements and Karen's statements. And just for the record, Vaughn Purdy and Karen Kelly's statements that, and I think we can sort of use a hybrid of the two. We should be looking for progress. We should be looking for quantifiable results. One of the quantifiable results you can look at over a period of time would be, how many cases do you have coming to court? How many drug-related cases do you have coming to court? If we see a falling off of those, then I think we're beginning to have some good effects. But that's just one metric. But I like what both Vaughn and Karen had to say about how we should approach this. I do think that a continuum, looking to continue the funding of things, funding of grants over time that seem to be doing the job, and also perhaps paring them back some, asking them to reach out into their communities, going to the people who have the most to lose, and that's the schools, law enforcement, county government, and our financial institutions, asking them all to participate, because our success is dependent on getting all of these groups together. And I think the last but certainly not least would be getting parents involved in these organizations, so that we're hitting all the major points in every community. But those are my thoughts on this.
Thank you.
What should we not fund? So, one is, I think we need to be careful about funding residential beds, just from the perspective of how we've got quite a few. Just careful. I don't know if I would say not, but just really question hard. I'm probably asking too much, because I think this would be too hard to do. But I saw when I sat on this was years ago, a United Way group, right? And I was sitting, and I was had just come out of the CHFS at that point, and I'm like, wait, they're asking United Way for stuff that we fund, and they're asking, and it's like, And so with this funding, particularly with this funding at the local level, and again, I don't know how you'd organize it. I don't know how you'd organize it. I don't know. I'm sorry. about, what are people funding at the local level, right? And it's not that if they're funding at the local level, we shouldn't do it necessarily, but we sure shouldn't do the same thing, right? And I think same goes for core funding. Commissioner Marks, I'm sorry, and your funding van, right? We've got some funding sources out of there, and I get a little nervous that sometimes we're paying for stuff that we are, you've heard me in some of the committees, again, all my healthcare friends in the industry will hate what I'm about to say, but we fund that industry pretty good, right? We fund them pretty good. I'm not necessarily sure that we should be, love you hospitals. I'm not so necessarily sure we should be funding them, right? Unless it's something super innovative. And then I do think we should talk about, and again, Vaughn, this goes back to you. What are we thinking? How long? Is there a time horizon on the funding? Are we, we do it. I'll give you an example. We got 7 little communities where we're doing some co-responder stuff, co-first responder stuff. And what we said to them is, we're funding you this year. All right, next year we're funding you 70%. Next year we're funding you 50%. You got to find it, right? We told you we're not going to fund it all. And we're going to decrease the funding as we go forward. So, but they know, right? And it gives them a little horizon to figure out and scramble, to figure out where they're going to find the other funds, right? Gives them time. And I think if we could figure something like that out, it would be great. I think it'd be great.
I think you just said it.
Sorry.
Yeah, I think if you've got organizations that have been doing really good work for 20 years and they're making a difference in the community, I think taking funding from, or not taking from them, but not including them is probably a little unfair. When I think of things not to fund, I was thinking back to my days at Unite, and it's been a day or two, but I was thinking we had extra restrictions on some of the asset forfeiture dollars. Chris, you remember? So things like vehicles had to be used for a specific purpose. So we just had an extra set of rules around those types of purchases. Definitely not against that, but I think, things like vehicles can get us in the newspaper headlines pretty quickly. So I think not to throw the baby out with the bathwater, but I think you have to think about those things and how you would make sure that they're used for the purpose as intended. Indirect costs, I think it's good to have that conversation. I know some institutions like colleges and universities have like a 45% indirect cost rate. Do we want to fund that? I think that's a big ask of these dollars. And also things like marketing and miscellaneous. I think it just, having a clear budget when you're looking at those items, those are line items that in the past I've always just said we can't fund anything that says miscellaneous, even if it's $500 or under. I want to know what the money's going for, and we can't fund marketing per se. Now, if it's targeted to get the hotline number out or something, I think that's not really marketing. I think that's education, but I would be really cautious of those type of line items.
May I add one thing?
Absolutely.
For my legislative friends, right? You got to have a 2 or 3 year horizon, because if something's really worthwhile, super worthwhile, they can come back to the General Assembly and say, hey, this is worth putting in the budget, but you can't do it you can't do it shorter than a biennium. And this is just me being the bureaucrat that I am, right? I'm sorry about that. But right, you got to have 2 years of experience before somebody can come back to you all and say, hey, this is work. And maybe even like we could do it, right? We could say to General Assembly, hey, this stuff's working. Might really be good to fund. I'm just sorry, just an addendum to the idea, and because I've got some friends down there. I'm trying to, how can we think through together, right? We're asking everybody to partner on it. How can we think through together in a way that we do this funding that can help when it comes to the time when you're doing a budget. Sorry about that, editorial.
Okay, I think a lot of my thoughts have been, but I wanted to revisit things that we should not fund, or we can discuss it another time. But the question is new construction. I mean, that's like a buzz for me. Like, I wish people did new construction because Simmons would take advantage of it. Simmons College would. So I want us to think about not funding new construction because it would get really, really expensive. And I don't think we'd really be able to fund that. So I wanted to list that. And the vehicles, I think if we have a policy on doing vehicles a certain way, I mean, I would give in to that. I mean, we had said no vehicles, but it's a discussion I think worth having. Finally, I'm going to bring this up because it should be brought up. I think we all love churches and go to churches, and is a question, you know how many churches there are in Kentucky? Does anybody know how many churches there are in Kentucky? A lot of churches in Kentucky. In the West End, there's probably 2,000 churches. So if we start funding churches, how do we look at funding churches? So there's no answer to that today because it gets you down a hole that you can't necessarily. A lot of churches do great work, but they're not directly doing this kind of work. Like they don't have addiction services in their churches, not many of them, but they do great work. I mean, praying works in some cases. So I think that's just a slippery slope that we need to take a look at. If we do churches, the churches need to be directly track record on doing something like this, like in a family, if they have a family life center or something that does it. There might be something like at Bates Memorial that they already do. But they can't just come to us because we're a church. We deserve to. And I'm not making the rule right now. I just think that's something that we should discuss. Churches.
Mr. Chairman, I think Vaughn is right. I think I'm not saying that the churches shouldn't be a part of this, but what we were doing was collaborating. We were making them part of an anti-drug coalition. We weren't making them grant applicants, but what we typically did was we had people who, when we were reaching out, that we reached out to on behalf of addicts, we reached out to churches that had Celebrate Recovery, for instance, and had programs that reached out to the addicted, whether it was Celebrate Recovery or some other programs. And they also had what Vaughn referred to as family life centers, and many churches do. So they were able to provide clothing, and in some cases, furniture, and in some cases, they were able to provide cars at a discount. One of the things you'll see at Southland Christian are those very programs. But back in Garrett County, we have First Assemblies of God who help people with the same issues. So I think Vaughn wasn't saying exclude churches, but make them part of the solution, but not the whole solution.
Thank you. So,
Was I right about that?
okay. All right. Mr. Ingram?
I'm really cautious about funding any more residential treatment beds and expanding residential treatment programs. I'm really, really cautious. I'm probably not going to vote for that. Just because there's other needs we have that aren't met, these needs are met. The issue of indirect costs, we had a lot of grant applications that were asking for help with rent, office supplies, phones, computers, and then wanted 10% indirect. That's what indirect is in my mind, is all those kind of things. So we need to look at a policy. If we're going to fund rent and utilities and all that kind of thing, we shouldn't be having an indirect cost as well. So there's got to be a line there, and I think staff did a good job of weeding that out in this last cycle. But I think we need to make that clear to the grantees, so when they write the grant, they know don't write for this. Back to something Karen said. I struggled with a number of applications that I couldn't tell they had any Kentucky connection. Somebody in Chicago wanting to save us from ourselves. I'm never going to vote to fund those. If they're not a clear Kentucky established connection, I can't go there. The same with new construction. Man, we can spend a lot of money 2 years from now, that place went out of business, and we don't have a clear deed to this property. What are we going to do now? So I think we have to stay away from that. Something that Secretary Friedlander mentioned, and we have this in our committee all the time, is what they're asking for being funded somewhere else. For example, we had a lot of requests to pay for staff, clinical staff. At the same time, I know these people are going to be billing Medicaid for those same clinical services. So if we're paying salaries of people that are providing these services, at the same time they're billing Medicaid, that don't feel right to me. That does not feel like something we should be doing. But we had application after application asking for a year's worth of funding of everything. And oh, by the way, we're going to bill Medicaid for these services. Now, they didn't put that on their application, but I know that's a billable service, and their providers, they're going to do that. So I think we got to pay a lot of attention to that. It was good being on the committee because a lot of the things that were being asked for, I know CORE funds that because I work with CORE every day. I know DOC provides this service because I work with them every day. I know Medicaid pays for this. So we got to be really careful about double and triple dipping that a number of applicants tried to do. I don't know. There were a few of them that we agreed we'd help somebody start up. Maybe we'll help with salaries for a couple of months, but by that time you should be up and going and billing and able to support that service yourself. But most of them ask for a full year's worth of help. Finally, I want to go back to this vehicle thing. When I first started granting money out of ODCP was 2015. And we were community mental health centers and neonatal abstinence centers, and we had a no vehicle policy. But over the last 10 years, we have shifted on that because of what we said earlier. Transportation is a big deal in this state. And a lot of times, a van or the right kind of vehicle provided to a nonprofit provider, instead of everybody coming to them for services, they can go to people for services. They can go to small communities that don't have a doctor and see 10 people out of that mobile unit. What we do with the vehicles that we do fund is we require a log of every time that vehicle's in service, who's using it, what was the purpose of that use, where did it go, and had it come back. And that way you can inspect that log periodically and see if there's any abuse. That's not foolproof, of course. But anything we fund can be abused in some way. And we'll never have enough staff to follow every one of these dollars around. But I do think with the transportation problem we have in this state and really in this country, that we might want to look at some vehicle purchases. Not a blanket policy that we're going to buy vehicles for everybody that asks for it, but if it makes sense. I'll stop there. Mm-hmm.
I've got nothing to add.
Thank you.
Van spoke for me.
Thank you very much, Dr. Roop.
Yeah, I'll echo that. Van has pretty much shared a lot of the things that I had written down here, and actually Ms. Karen earlier had as well. I think what we've seen a lot is, for those organizations that are outside of the state, that have come in requesting funding, I think I think we can produce that help here homegrown.
That's right.
Kentucky. And as well, we did those town halls when we first did the commission was announced. We did, I think it was 12 town halls from Ashland to Paducah or something like that. And we were encouraging people to, let's see some grassroots organizations come forward. And I can say now, kind of like looking back, I'm really proud of the work that we've done on the commission, particularly our subcommittee with treatment and recovery. But I can't help, if I'm being 100% honest and transparent, is like, I wonder if we're not just kind of supporting those efforts that have gotten us to this point where the results are mediocre at best. And I think that's a tough statement to share, and what it indicates or points towards is, again, I think it comes back to the innovative And I really appreciate what Van had shared earlier and some others. Like, yeah, we recognize, and I think Dr. Friedlander, like, there needs to be set aside a pool or an allocation for those innovative organizations that are trying something new that may be more transformative than what we're already doing. So I think, in my mind's eye, I think like having an awareness of that will be helpful and impactful as we move forward.
Thank you.
And earlier, I do want to clarify my comment about the DARE program and what the founder had said. My point of sharing that was that when we're talking about collaboration, a lot of times we can say that we're collaborating with others, but we really kind of hold back in terms of organizationally, not only funding, but resources and efforts, and that kind of reduces or diminishes our collaborative efforts. So DARE did help. It did work for me when I was in school, so I do want to reiterate that.
Great points by everybody, and I don't have anything other than, you know, I like the fact that we don't purchase land. I like the fact that we're careful about office supplies. I like the fact that vehicles, transportation's really kind of been hit home to me today, Van. You had some great points. You know, it was mentioned today in one of the presentations, a first responder diversion center. You know, I was talking to my son Saturday night. He was off duty. My son's a trooper. Let me clarify that. And we were having a conversation about life in general, and he said, "I got to go, Dad." I said, "What's up, son?" He said, "I got to go." And I could hear some people arguing in the background, and he had rolled up on an individual in crisis. He'd got a hold of some bad drugs, still we don't know, and he had to convince this individual, "Hey, will you go to the hospital to get checked out?" Because the family was upset and crying. It was right in the middle of the roadway. So he had to intervene in this situation. It was about 7 o'clock on a Saturday night. So where are all the counselors? Where are all the peer support specialists? They're home, they're on vacation. My son yet is thrust into this. The police are often get blamed for a lot of this stuff, but there's no place to take these individuals, folks. And I'm speaking from a treatment aspect here. On Saturday night at 9 o'clock p.m. And the police are left to go take them to jail. And jail's a bad word. Nobody likes it. I understand. But the reality is when people are exhibiting behavior, be it they're choosing or be it maybe a mental health episode, and they've shown they can't get along with others or they can't function, there has to be somewhere for them to go. So I don't know that I liked what the presentation said. It was called a first responder diversion center. That makes us feel better because we're not putting them in jail, but there has to be a place where my son can take these individuals who are in crisis at 9 o'clock on a Saturday night. So I represent the law enforcement component, and I want to make sure that I always do that to the best of my ability. And that's just one thing that I would like to maybe see that we could maybe take on in the future, some of these diversion centers.
Thank you, sir.
I really don't have anything to add other than just to make sure that every penny gets to the people who need it. And whether it's prevention, treatment, jobs, whatever, make sure that people's not gobbling up the money to pad their pockets and the people that need the help don't get it.
And I want to make sure we don't forget, our guest on zooming in, Dr. Freeman.
Thanks. Yeah, thanks. Not much to add. I mean, Van covered a lot of the things that we talked about during our committee meetings, but I do want to just circle back around to the indirects because, I mean, there are valid, I think, reasons for people to think about indirect costs as part of, carrying out the activities that they outline in their grants. I think the problem that we ran into was this double dipping, as Van says. And so thinking about, putting in place with our, request for applications that it's clear, you can't itemize indirect costs, and there will, we can charge up to us, I think the state usually caps their indirects at 10%, if I'm not mistaken. So, thinking about that and coming up with some, guidance, if you will, for the grantees would be important.
Thank you. That's very helpful. going last, the one piece that I hadn't heard, and thank you very much for everybody going through, and this has been a great process, and we're closing the loop on this. The one thing I just would want to add in is I'd like to see whether or not the consideration by the commission for sustainability. And the thing that I hate to see is that we fund somebody for 1 year, and if we don't fund them at all, they're going to go away, and we put somebody down that road. I recognize that there are some things and some organizations and some work that's being done that the only way they can survive is based off of grants. And so I recognize that you can't just say, hey, if you don't have a sustainability plan, we're not going to provide you with the award. But I would like for people to come in and tell the commission how they plan to have some legs in terms of this program, to make sure that something we fund and support lives on in the communities, and the community gets a benefit for more than a year or two. So I just want to bring that and make sure to put that on the record. That being said, those are the three questions we've gone through. What will follow from this is trying to pull this information together by staff to make sure that the next time we can have a more further discussion and understand and say, here's what the comprehensive views were of people, and here's what it looks like when you get it together, so that we can kind of move forward with that, and again, keep this prioritization process going, so that we can include this in the notices of funding, so that organizations know when they apply, this is the things that they're going to accept, this is the things they're going to support, these are the things that they don't. And I think that will help all the commission members and the organizations. The only other thing, there's two things left on there.
Sorry, can we just, since we just have a few minutes, there are two things I didn't hear anybody mention.
Yep.
That's the cap on the amounts, and getting some thoughts about, because I heard some different things around, funding at different levels. So if there are thoughts about how you would like to see amounts or notice of fundings, we've capped it at $1 million in the last one. That also means lots of people are asking for closer to $1 million who maybe would benefit more from a small grant. So just would be curious about any thoughts around amounts, and then also whether or not there's a preference to looking at something other than a 12-month, knowing that we have to contract on a biennial way. Do you want to see applications that would propose a 2-year plan as opposed to just a 1-year plan? So would just be curious on your thoughts there.
Yeah, open that to the group.
I think it would only be fair that we look at them 1 year at a time. I don't know. I mean, it depends, I guess, on the turnover. I don't know if we have any turnover coming up. Is it fair for us to grant one for 2 years? I mean, what do we think? Oh, sorry. Is it fair for us to say this is a 2-year grant? They're here for 2 years. But I mean, it's something.
You guys get to make that
can-
call. That's
yeah,
why I'm
that's what I was gonna
asking.
say.
I mean,
That's
we would
something-
budget accordingly.
Right.
I mean, we wouldn't be giving out money we don't know we're getting. So it might reduce the number of applications in a particular year if one was going to be spread over 2. But just wondering if that.
So spread over 2, like if someone asked for $1 million, they'd get $500,000 over 2?
It depends on, and this has come up in one of the subcommittees before, that, hey, should we look at multi-year grants? And you're right, we did not bring that up in the discussion. So,
Well, if you're thinking about like a mentoring program, it's really hard to do that in a year and start building relationships. I think in an instance like that, it could potentially make sense. I would leave it up to the grant recipient to request how much money and what budget they need. There's a lot of programs that's really hard to pull off, and especially if we're talking about innovative or new things, even if it's a new program by an organization that already exists, it's hard to get things in place to do that. But maybe they could do it in 18 months to 2 years.
We saw that with a lot of people who were applying for a second time around, and we asked staff to dig into it, and they hadn't spent but 25% of what we gave them last time. So it's really hard to give somebody another $1 million when they haven't spent a small portion of it. And I don't know where we came up with the $1 million cap. It seems awful high to me.
I agree with you on that. I think the $1 million is too high.
People write these grants like we got all $498 million available to us right now.
And they wrote grants for $999,000.
You know, and this money is spread out over 17, 18 years. At $1 million a grant, we can take 10 grants and about spend all we have available. So
So we can.
I'd like to revisit that cap.
I would too.
That was the question I was going to ask to those two folds. One, we'll put that on those revisiting the cap into the terms. Do people okay? And the terms, the length of terms for those points. Is there anything else from?
I would say again, maybe there's a, I don't know, maybe there's a grant or two where we're saying, yeah, these are really our partners, and we're gonna fund them, right? We love them, but I think there should be a whole different set that say, yeah, we'll give you this year, but it's gonna go down, right? We're not giving you the same amount. You have to find where other funding's coming from, and give them a glide path off, right? I think that's honest with the folks who are asking for money, right? And if we're interested in innovation and having funds where innovation occurs, we can't give money to the same people every year, right? So how long is that? 2-3 years? I don't know, but I think it'd be a worthy discussion.
We'll include that in the next round of conversation about this topic. So thank you. Anything else from you? Okay. The only other thing that I might should move this out. Does anyone have any new business which needs to be raised at this time? Yeah. So seeing no other new business, the only other thing that I want to make sure to point out to the folks here in the last few months, we in the commission staff have had the benefit of having 3 people who spent some time with us, college interns, and I want to recognize them for their assistance in the work that they've done. A lot of the information that's been provided to the commission members, a lot of the work that's gone out to plan the site visits, to do a lot of work that you will see even after they're gone, is because of them. So we want to make sure that we thank them and let them know we appreciate their service this time. So, and with that, I will thank all the commission members and ask if somebody would be willing to make a motion for adjournment.
Make a motion for adjournment.
All right. We have a motion and a second. We are adjourned. Thank you very much.
Thank you.